I request all the dignitaries to please take the seats in the audience. To kickstart the ECG Symposium, I invite our first speaker of the day, Dr. Malav Zala. Sir will be deliberating on ECG markers of sudden cardiac death. Sir is consultant electrophysiologist and interventional cardiologist at Criticare Asia Hospitals, Mumbai, BSES Global Hospital, Mumbai, Associate, the Arrhythmias Associated, Mumbai. Sir has many awards and honors to his credit. The short-term studentship national level undergraduate research program by ICMR, council member and general secretary of the undergraduate student council, and sir is also trained at the Bhabha Atomic Research Center, Mumbai at the year 2015. Over to you, sir.
Hello, yeah. So thank you for that introduction and good morning. It's an honor actually to start off with this topic. It sets the mood for this ECG symposium. Now, ECG markers, so as we have all been talking and our honorable chairpersons here alluded to that the electrocardiogram is something which is handy and which is useful. Not only that, its correlation with the background clinical scenario is of utmost importance because the ECGs may be abnormal, but the patient has to fit into your clinical decision making. So this topic that I have right now, so I have designed it in such a way that we will be discussing diagnosing or hints towards patients who already clinically you suspect as having a risk of sudden cardiac death, and whether you should refer them or whether you should work them up or you should just refute them and keep them on a follow-up. Of course, it's a very large topic and I apologize if I exceed the time, but I feel that today in this age, in India at least, we should really be looking at sudden cardiac death. We have moved on from rheumatic heart diseases, tuberculosis, and now we are looking at so-called normal deaths in young, and it's a good idea to just revisit this for some time. So of course, to begin with, we have a few terminologies that we typically use. So sudden cardiac arrest, as we all know, is cessation of normal cardiac activity with hemodynamic collapse. Sudden cardiac death is of course presumed death because of a cardiac cause, and if it's witnessed, then within 1 hour of that witnessed event, onset of symptoms, or within 24 hours of last seen alive. And of course, unexpected or unknown autopsy negative deaths are also taken as sudden cardiac deaths. You have a relatively newer entity called as the sudden arrhythmic death syndrome. Again, that's unexpected death in more than an infant age with negative pathological and toxicological assessment. So it's basically most of the relatively normal deaths that we encounter. So all of them are presumed to be sudden cardiac death unless proven otherwise. Now, this is of course the Western data, but you can see that 50% of cardiovascular mortality is sudden. And the incidence of course increases with age, from being 1 to 1 lakh to about 2 to per thousand in the 7th or the 8th decade. And today in our practice, we have a sizable population about the 8th decade, sizable about the 9th decade as well. So it becomes clinically important for us. Of course, the most common cause of death continues to remain coronary artery disease, but there are other etiologies which we can and we should look into. Now, if you can see on the right, it's a very historical graph. It tells you the incidence of sudden cardiac death amongst various populations. The left side of this particular graph shows you the general population has the lowest percent incidence. But if you look at absolute numbers, it's the highest. Because the denominator is more, your percentage is obviously going to be higher. So that means that you are going to find much more structurally normal heart related sudden cardiac death patients in your general practice, even though you may look at the percentage to be less. Of course, if you have a young athlete male and he has a sudden cardiac event, again, that's most of the times because of an arrhythmic event or a sudden cardiac death. And again, with the current marathoners and the current exercise schedule that most of us advocate to, it is something again which is, I believe, much more common in our practice. Now, the etiology of sudden cardiac death is varied. But as per age, if you go to see, barring coronary artery disease, which today I believe it can happen in anybody and everybody. We have seen coronary artery disease getting patients coming at 16 years of age, even younger. So barring that, if you have a relatively younger patient, you look at channelopathies or electrical diseases or structural heart disease. It may be congenital heart disease, it could be ARVC, it could be hypertrophic cardiomyopathy, or it could be post-myocarditis, LV dysfunction, genetic cardiomyopathies, or coronary anomalies. Of course, in elderly population, it's relatively easy because apart from ischemic heart disease and valvular heart disease, we may have a subset of non-ischemic subset in the form of sarcoid, infiltration, amyloid. And of course, this led to, in 2022, the European Society of Cardiology and EHRA, that is the European Heart Rhythm Association, to bring out a set of guidelines and a guidance document on sudden cardiac disease assessment and its possible management. Because there is a lot of controversy in the management and we needed a headway. And this particular cartoon on the right side very lucidly tells you what type of monomorphic or a polymorphic VT would be the terminal event in a particular etiology, in a particular age, and with the sex distribution. So this is one cartoon which is a central illustration of that particular document, and it kind of summarizes our entire talk. So if it's a CPVT, it'll happen in exercise, it'll happen in a younger age. If it's HCM, it has a bump in the middle age. Patients of pathology of fallow or congenital heart disease will have two bumps, one when very young, one when in the middle or the older age, if they survive to that age. So it's a good document and it's a good illustration to keep in mind. Of course, the management part is pretty straightforward in terms of if you have a VT, what do you do? You try to decide whether it's a monomorphic VT. Of course, we'll see a few examples later. And then the management, of course, depends after you have taken care of the VT episode. Do you work them up? Does he require an ICD? Does he require an ablation or just an arrhythmic drug? Coming to the main topic now, ECG markers. So ECG markers, again, they are not definite and they are not solitary markers. They have to be first, it is a group of ECG changes that you will see in the entire ECG, and it has to be correlated with your clinical history or a clinical diagnosis. There are a few characteristic ECG changes which we will discuss, and so if we look at them, a few of them I have marked it out. One is the fragmented QRS, the low voltage QRS, the epsilon and the Brugada pattern, a few of the repolarization and T-wave anomalies. Now most of them will denote a scar in the myocardium. When there is conduction slowing, you will have fragmentation. You will have low voltage because the electrical myocardium is replaced with something which is not conducting. If it's completely replaced as an infiltrative cardiomyopathy, obviously the voltage height goes down. If it's heterogeneous, intermixed with normal viable myocardium, you will have conduction slowing, and that's all that we are looking at in most of these patients. Of course, there are certain channel-related problems which can change the action potential of the myocardium, and that's why you have certain repolarization abnormalities and T-wave abnormalities. So, as we know that the cardiac conduction system is heterogeneous. The conduction system itself, it has a higher resting membrane potential, and that's why it is more excitable, whereas the cardiac myocyte has relatively 5 phases, or phase 0, 1, 2, and 3, and 4. And it has a lower resting membrane potential. So basically the conduction system drives the myocardium. Again, every place anatomically is different. So an epicardium, mid-myocardium, and endocardium, all 3 layers have a marginal difference in their action potential durations. And that's why our conduction system flows from base to apex and then back to the posterobasal region, endocardium to epicardium, and vice versa when it is repolarizing. Now, this marginal difference between the thickness of the myocardium is in normal people. Some patients, especially with Brugada syndrome or any of the repolarization abnormalities, because of the channelopathies, they will have a significant gradient from the epicardium to the endocardium. And whenever you have this kind of anomaly, you will land up with some of the other ECG changes. And the vector law is universal. So if you have, all our chest leads are anteriorly placed. So if you have a vector which is coming from endo to epi, then it's towards the anterior chest leads. It is likely to produce a positive deflection. If it's epi to endo, it's likely to produce a negative deflection. So if you keep this in mind, you will be sure that you will never go wrong while interpreting ECGs. Again, just to touch upon the absolute and relative refractory periods. Now, this is important because what I'm showing right now is the cardiac myocyte action potential duration curve. What all that you need to know is that in the phase of repolarization, almost from the onset of depolarization to the 1/3 or 2/3 of the repolarization is an absolute refractory period. Generally, things don't go wrong there. Things go wrong either before or after, especially in that sweet spot of the relative repolarization. If you have an action potential or a PVC which happens to come during this time, which we sometimes allude to in bradycardias as R on T phenomena. So that action potential comes during the time when the myocardium is relatively refractory. It can start off a volley of ventricular tachycardia, and that's what we need to be sure of. And that's what we are trying to eliminate when we are trying to treat these people. Now, again, sodium and potassium channels, again, it's a very dry topic right now. So you just keep in mind that these are 2 channels which can many times cause channelopathies, and most of the patients with genetic cardiomyopathies will come with channelopathies around sodium or potassium channels. This we have already discussed as due to the gradient. So to summarize, the spectrum of sudden cardiac death, while reading, this is all that you're going to see in a patient. All that I talked to you right now was all theory. You will get a patient with an ECG. So where all should you be looking at or concentrating? So you look at the PR segment, because fibrosis of the conduction system from the atrium to the ventricle is one of the commonest bradycardias that will come. It will be a first degree AV block or second degree AV block or a complete heart block. Many times they'll come to you with a sinus ECG, but they're going intermittently into complete heart block. So the PR interval is the zone where and these patients, if not treated, definitely will have a sudden cardiac death because of bradycardia. So that is the first segment. Second is the entire QRS. You look for duration of the QRS, the height of the QRS, the nature of the QRS, the quality of QRS, whether it's fractionated, whether it's sharp. Look at the repolarization part, ST segment and the T waves. Is there ST elevation? Is there T wave inversion? Is there a QT prolongation? All of these are markers of sudden cardiac death. So very quickly, as we discussed, fractionated QRS denotes a scar. A QRS which is broad or narrow with 2 R peaks or an RSR is all that is required for you to suspect that this is possibly a fractionated QRS. It's certain locations in the ECG can denote or has been studied to have a poorer prognostic factor, like hypertrophic cardiomyopathy with inferior leads, lateral leads in general population, or structural heart disease patients with a fractionated QRS will have definitely more scar, hence more risk of sudden cardiac death. Hence they may need an ICD, or they may need some workup beyond just GDMT or guideline directed medical therapy. The limitation is if you do a random screening of all of us, you will find some fractionation. That's where your clinical context comes into play. Then of course the Q waves is something which all of us have aware. It denotes Q wave regardless of the etiology denotes a scar. And if it's there, you need to be sure that this most common being a MI, but if it's a not MI subset, then look for some structural heart disease. A QRS width, again, wider the QRS, slower the conduction, poorer the LV function, more chance of death. So when you give them device therapy and we shorten the QRS, there is no absolute number, because even a 10 millisecond reduction causes a significant improvement in mortality. Then we have something called as a left posterior hemi block. Now the left posterior hemi block is the rarest of the hemi blocks that we see, or IV intraventricular conduction defects. Because it's located posteriorly on the basal aspect, it is least likely to be affected by physiological problems or structural intervention as such. But if it's affected, that means the conduction system fibrosis is so extensive that it's extending posteriorly. Secondly, in non-ischemic cardiomyopathy subsets, the posterior-basal section of the LV is considered to be the most prominently affected. So if you have a patient who has a narrowish QRS, inferior axis, and possibly a RS in one AVL and a QR in inferior leads, which is left posterior hemi block. Inferior is posterior in ECG, so 2, 3 AVF are inferior leads. If you have a QR pattern there, it's generally a posterior hemi block. So if you have this kind of a pattern and if you have LV dysfunction, again, you expect the scar to happen at the left posterior basal region or the posterior part of the LV. So again, a LPHB on its own is something which we need to not just disregard as an aging anomaly, which we many times do with left anterior hemi blocks or incomplete right bundle branch blocks. Now a signal averaged ECG is something which a decade ago a lot of interest was there in trying to get you this signal averaged ECG. It's basically when we do electrophysiology studies, when we are looking at the EGMs or the intracardiac electrograms, or even the surface ECG from that matter, we blow it up with a lot of filters, and we find that the end of the QRS, because of the conduction slowing, is a low amplitude, high frequency noise. Now that's not noise, that's basically the local conduction slowing happening at that region. So people tried to really reciprocate this in the clinics. It didn't work out because it was too tedious to do it, but it's something that sometimes you may just catch on when you're reading an ECG. Look at the end of the QRS, and if it's not sharp, something's wrong there. Of course, you need to rule out that there is no noise in your ECG system, the wires are well placed, and there is no break in the insulation of those wires. Now these are epsilon wave and the Brugada pattern are two characteristic ECGs which many times we get in our practice, especially in younger people. So it's the ARVC predominantly affects the right ventricle, not only but predominantly the right ventricle, and hence the entire QRS is a summation of the depolarization of the left ventricle and the right ventricle. So if there is conduction slowing on the right side, you will have a terminal bump which is called as the epsilon wave. Now the Brugada pattern again is something which there is a controversy as to whether it's a depolarization or a repolarization anomaly. Notwithstanding that, if you get a young patient, structurally normal heart, ST elevation in the anterior leads, please look at this. It could be evoked by fever or spontaneously. Early repolarization syndrome, again, it's a very discussed entity. In patients with select subset of high-risk individuals, the early repolarization syndrome is a marker of sudden death. But if you just do a random assessment, you will find a lot of people, younger people coming with a so-called ERS. Structurally normal heart doesn't need any sort of intervention. Again, the T-wave disorders are something which were again alluding to a repolarization anomaly. When you measure the QT, you look at the end of the T, onset of the Q, and that is the QT. Now, is there a single number? There's a lot of variation in the data, but for you, if you have a young patient, male, it should be more than, if it's more than 440, young female, more than 450, it is QT prolongation. Very quickly, I'll just show you a few cases. You can stop me whenever you want. 74-year-old diabetic hypertensive, HFpEF. He comes to you with an unwitnessed syncope, which was 6 months ago. Now he presents with worsening heart failure symptoms. Your resident calls you up saying, sir, he is dyspneic, but his heart rates are not going up. I'm sharing the ECG with you, just have a look. You look at the ECG, you first find that, look carefully at the chest leads and the limb leads. There's a discrepancy. There's a right bundle in the chest leads, and there's a left axis in the limb leads. Whenever you have this kind of a discrepancy, you look of conduction system diseases. What are those? This is called as something called as a masquerading bundle branch block. This is an early form of complete heart block. So if you have this, there is a chance that if you leave this alone, this patient will come back or may not come back alive with a complete heart block. These patients go home with a pacemaker. It's extensive fibrosis of the conduction system. Then you have a 67-year-old non-diabetic, non-hypertensive, old MI, repeatedly revascularized, ischemic cardiomyopathy, single chamber ICD, upgraded, PTCI done, has come with recurrent ICD shocks and recurrent palpitations. You are escalating the antiarrhythmics. You don't know what to do. We get the ECG. He's on a dual chamber, a biventricular pacemaker. So if you look at the ECG, and if you see very closely, you can see that the inferior lead QRSs are all fractionated. As we said, there's extensive scar, and if you look at the clinical history, you expect this scar to be there, and you expect him to not do well. And that's important because this patient has a lot of substrate, a lot of scar. One PVC initiates the VT and he is miserable. So when you look at this ECG, even though we have a CRT in place, there are certain things which you will not be able to treat. And this patient, you need to explain to the relatives, you need to explain to the patient the prognosis. Of course, this patient can undergo a VT ablation or a 3D anatomical procedure, and we can improve the quality of life. But the ultimate goal in some patients is just transplant. Now this is a 20-year-old boy, high-grade fever. I believe a lot of you may have seen this kind of ECG now. A normal boy, normal ECG in the past, had a syncope. One of his elder siblings died at a young age. We don't know why. He's come from a rural background. You happen to see this ECG on the left, and if you see that there's an ST elevation in the anterior leads, and there is a T-wave inversion in the anterior leads. This is not an MI, it's a Brugada syndrome. As we already discussed what the Brugada syndrome is, we won't go into the details, but I need you to look at this ECG again. It's important because we miss a lot of Brugada, and we have a lot of Brugada moving around amongst us, especially in rural India. Again, the criteria even set by Brugada is that you need to have a clinical high-risk feature to advise them something. Most of the Brugadas, if they are non-syncopal, do not have a family history, you may just avoid Brugada drugs. There's a website where the drugs are being updated every day. So you just give them the website, avoid those drugs, and just keep a follow-up. But yes, if they come with a syncope, if they come with a family history of sudden cardiac death, or if there are some well-to-do patients would have a gene study done already, those are high-risk subsets, and you may offer them an ICD and then later on decide whether they need any other intervention or not. So this is of course the genetic testing. This is again a 45-year-old male. He had come to you with seizures during sleep. We are not sure what it was. Again, the sibling had died at 32 years of age, and the neurologist has cleared him, there is no epilepsy. So he comes to you. And you look at the inferior leads, and you see that there is that repolarization, QRS fragmentation with an ST elevation. So this is typical of ERS. Again, ERS, you need to take a informed decision with an expert whether they need any further intervention or not.
Sorry to interrupt you, sir.
We
Please
are
make
done.
it short.
I'm done. So just one last one is a 35-year-old doctor, and he comes to you with a history of two of his siblings dying suddenly. Now these, of course, you can see the history is all exaggerated. It's because you need to understand, if you don't ask, they won't tell you that there was a sudden cardiac death in the family. Now this guy has a QT prolongation. Subsequently, we found that this guy had a familial long QT syndrome, and these patients may either need a dual chamber ICD or a pacemaker depending upon the decision that we take. So this is, of course, just the last one is 70-year-old diabetic hypertensive with an ICD. You escalate amiodarone because he had a VT, and you find that the VT is worsening. So if you look closely at the ECG, the QT is already prolonged, so you don't give QT prolonging drugs. Amiodarone is a QT prolonging drug. You have to withdraw it, sedate him, paralyze him, put him on a ventilator if required, start non-selective beta blockers. So to conclude, sudden cardiac death is an important cause of death in general population. History and clinical evaluation are pillars of diagnosis. ECG is the soothsayer or the storyteller. Thank you.
Thank you, sir, for your valuable insights.
Yeah.
We can take up questions at the end of this session.
Sure.
We have the next talk on electrical solution of heart failure by Dr. C. Narasimhan, sir. He is on Zoom platform. Sir has a clinical experience of being a director of cardiac arrhythmias, chief cardiac electrophysiologist, AIG Hospitals, Hyderabad, fetal consultant cardiologist, Care Hospital. He has a fellowship in clinical cardiology, vascular disease, clinical electrophysiology, to name a few. The position, sir has an illustrious CV, being the past president of Indian Heart Rhythm Society, past president Indian Society of Electrocardiology, editor-in-chief of Indian Pacing and Electrophysiology Journal. Sir has many positions to his credit. The awards sir has attained are S. Goldsmith Award for Professional Competence at Chicago, Best Teacher Award at Chicago, A. Goldsmith Award. Sir really has an illustrious CV. Over to you, sir. There is some technical glitch, so we cannot connect with sir. We go over to the next topic of pre-operative evaluation for non-cardiac surgery with emphasis on ECG by Dr. Pankaj Harkut. Sir is a renowned interventional cardiologist of the city, Director, Swasthyam Hospital, Joint Secretary, CSI Maharashtra. Over to you, sir.
Is there any pointer? So good morning. Malav has done most of the work, pre-operative evaluation and emphasis on ECG. So basically pre-operative evaluation is basically done to avoid and to predict the perioperative mortality, which happens with almost 43 lakhs death happens perioperatively. This is annual data, and the number of these, many of these patients are avoidable. Many of these patients do die of cardiac deaths, and many of these deaths are avoidable. What needs is the careful perioperative evaluation of these sick patients who need surgery. And we will be emphasizing on the cardiac marker, most important of which and most easily available of which is ECG. So as I discussed, the goal of any perioperative evaluation, preoperative evaluation is to identify high-risk patient. The goal is not to give medical clearance to the patient who are posted for surgery. Most of the times what we get call is to give clearance, to give fitness to this patient, but that is not a proper way to evaluate this patient. Proper way is to evaluate and identify the patients, identify the risk factors, identify the patient who are at risk of sudden cardiac death or who are at risk of major adverse cardiac event perioperatively. And then after we have identified these patients, there is a need for stratifying these patients, whether these patients are in mild risk, moderate risk, intermediate risk, or the patients who are high risk. And then finally communicating these points to the team, that is to the anesthesiologist and surgeon, because they can modify their strategy on the basis of this stratification. And lastly, on the basis of this stratification, there might be some preoperative things which can be done to manage the risk. So these are the 4 things which we have to done when we are doing the preoperative evaluation. And why there is a preoperative risk, as we understand that a patient who has come for surgery may be in emergency or maybe it can be elective surgery, but it's a silent pond, and a surgery is a stone which we put this in a silent pond and it will splash the water everywhere. And that's how we have to take this surgery, and that's why we have to take these episodes very seriously, because there is a major hemodynamic stress, change in cholinergic, adrenergic activity, temperature fluctuations, and fluid shifts, as well as pain. So all this muddles up the patient who is silently managing his risk. And when you add surgical stress to this patient, that shifts everything. So basically, whenever we are evaluating, we have to evaluate these patients on 3 parameters. What are these 3 parameters? One, we have to understand what is the surgical risk. Many of the times we are not told as a physician what exactly is the nature of surgery which surgeon is going to perform. But it is very important to understand the surgical risk and stratify the patient on the basis of surgical risk. So patient who is high risk, like emergency major surgery, peripheral vascular surgery, or aortic surgery, or surgery involving excess blood loss, if fluid shift is going to happen, that will be a high risk surgery. So we have to identify the surgery which is high risk, more than 5% perioperative mortality or MI risk. Then moderate risk surgeries are mainly carotid or endarterectomy, urological, orthopedic, or abdominal procedure. Low risk procedure are the procedure where many things are not required. Many the careful preoperative, here we have to be very careful in advising the evaluation. Why? Because here over evaluating the things will complicate. So there are 2 extreme subsets. One, high risk surgeries where we have to be very careful, and one where low risk surgeries where we need not be that careful, because that will increase the patient anxiety, that will increase the added financial burden of additional tests, which will not help in the perioperative management of this patient. So these 2 extremes we have to manage, and we have to be in moderate zone. So first was identifying surgical risk. Second is identifying the clinical scenario in which patient is there. So these clinical predictors are very important. When we are analyzing patient, when we are identifying this patient, the patient is in acute coronary syndrome, unstable angina, patient who is decompensated heart failure or ongoing arrhythmias. So these are major clinical predictors. Along with that, if there are severe valvular heart disease is there, untreated valvular heart disease. These are the major clinical predictors which will identify the patient who is at high risk. Then intermediate clinical predictors. Again, here I will emphasize the acute or recent myocardial infarction. Acute is that the MI which has happened in last 7 days, or recent MI which has happened within last 1 month. So anything which is beyond 1 month is previous myocardial infarction by history, and the pathological QAs if these are present on the ECG. So this puts the patient in the intermediate clinical predictors. Less than 1 month is a high risk. After that, patient relatively is stable. So patient who has been treated for heart failure or compensated heart failure, diabetes mellitus, renal insufficiency, and mild angina, all these are the intermediate clinical predictors. Then finally, the minor clinical predictors. So here comes the abnormal ECG patterns, which left ventricular hypertrophy, the left bundle branch block, STT abnormalities. But along with that, there is no major angina or no major symptoms are present. Symptoms are not present at rest. So these are the minor clinical predictors. Only some ECG abnormalities. Advanced age, history of stroke and systemic hypertension, all these are minor. So first we have identified the surgical risk, then we have categorized this patient into 3 clinical predictor risk zones, that is mild, moderate and severe. And then finally we have to assess the functional capacity. So these are the 3 steps for each preoperative evaluation. We have to document what is the surgical risk, what are the clinical predictors in which patient lies, and finally what is the functional capacity. There is no need of doing any test for assessing the functional capacity. It can be decided on the basis of patient history. And if patient's functional capacity is less than 4 meds, then patient is a poorly, and that has got a prognostic value, that has got many implications how this patient will fare perioperatively. And if patient is good functional capacity, that rules out most of the things that will make the patient safe for surgery in most of the times. And then if treadmill has been done and the patient has been able to, patient ischemia level is low, that is less than 5 meds, patient is STT changes are there or angina is there, and if patient heart rate has not increased on the treadmill, so this puts the patient into high risk group. And if patient is able to achieve more than 7 minutes without any STT changes and the heart rate has increased more than 130, so these are the patients which will be low risk. So this is on the basis of functional capacity. As I mentioned, functional capacity, by asking simple questions, we can identify as per the Duke's activity status index. If patient is able to do household work and can walk for some distance, can walk a block, so patient is around 4 meds. And if patient is able to run, walk normally, can climb 2 or 3 flights of stairs, it's around 7 to 8 meds. And if patient is able to participate in strenuous exercise program like swimming or football, basketball, it's more than 10 meds, which is puts the patient into a low risk zone. So that's how identifying what is the functional status on the basis of history is very important. So we have identified 3 parameters on which we will be classifying: surgical risk, clinical predictors and functional status. Now coming to ECG, this is very important question. Should all patients who are going for surgery, is the ECG required? So as I mentioned, there are 2 groups. One which is very high risk, where definitely ECG as well as something more than ECG will be required. And second group will be a low risk group, which is going for a low risk surgery. These patients need not be bothered about ECG. So what guidelines recommend? Guidelines are, mostly these guidelines are based on low level of evidence and based on expert opinion. The current guideline indicates or recommends that perioperative ECG is must in which patient? The patient who has history of coronary artery disease, history of stroke or a peripheral vascular disease. And in patients, it is reasonable, that is recommendation is 2A or 2B for patient who is morbidly obese and with 1 or more risk factors for coronary artery disease. It is reasonable to get ECG, but do not order ECG in a preoperative patient who is totally asymptomatic and undergoing low risk surgery. Here, advising ECG and advising further test will unnecessarily make the patient anxious, increase the financial burden, and will delay the low risk surgery which is not required. And age alone, there was a study that after the age of 75, if we routinely do ECG in preoperative patient, it does not predict anything, because there are chances that there will be some ECG abnormalities, but that does not translate into better clinical outcome of this patient. So we have to be selective. We have to identify the patient who needs ECG evaluation, and on the basis of ECG evaluation, who needs further workup. Sometimes when ECG is done, it will show us the metabolic and electrolyte disturbances and intracranial disease, maybe some conduction disturbances, but this does not warrant further workup. The conduction disturbances like right bundle branch block, first degree AV block. In certain subgroup of patient, when patient is going for elevated risk surgical procedure, so high risk procedure and ECG is showing something that will predict MACE. So we have to be very careful in patients who are undergoing for high risk surgery. In this, even these minor STT changes, minor ECG patterns will predict major adverse cardiac event. So there are certain mimics, as we have discussed, Malav has already discussed about malignant early repolarization, but if sometimes the benign early repolarization is also present, when the concavity is there, J point elevation and with concavity upward, these are the patients which are there, which come to us for preoperative evaluation, but ECG, even if there is a ST elevation, it is a mimic which is happening there, it is not an acute MI which is happening. So a reason can be electrolyte disturbances, left bundle branch block, ventricular hypertrophy. And this is the same things which Malav has discussed, but I will stress, if we find these ECGs in a patient who has been done preoperatively, and these are the markers of sudden cardiac death, there can be certain depolarization abnormalities and repolarization abnormalities as well. Even if it is repetition, I will stress on few points here. The left posterior fascicular block, very rare to see this on ECG, but if it is there, because left posterior fascicular block got a dual blood supply, and if it is there, that suggests that extensive scarring of conduction system has happened. How to identify, we have discussed it, but if it is there, we have to take it very seriously. We have to screen this patient. And more than that, if the other parameters are also normal, we have to tell the anesthesiologist and surgeon that these are the patients which are at risk of sudden cardiac death otherwise also, and perioperative changes may make them more vulnerable for sudden cardiac death. Then one point was T peak to T end. This is another. So if we go for peak of T waves to end of T waves, if it is more than 100 milliseconds, that suggests that there is a scarring in this patient. This is a repolarization abnormality which happens and suggests that these are the patients who are vulnerable for sudden cardiac death and arrhythmias. And others are like if scarring is there, if there is a scarring because of ischemia or because of cardiomyopathies, the QRS will be fragmented, the QRS voltage will be low. QRS voltage low we can determine on the basis if the S wave in V1 and from V2 to V5, if R wave height we measure and the sum of this is more than less than 15 millivolt, then that suggests that this is a low QRS voltage, suggests that there is some extensive scarring is happening, LV dysfunction, possibility of LV dysfunction, and this patient needs further cardiac workup on the basis of ECG alone. So finally, how to go ahead in clearing this patient, how to go ahead in stratifying this patient, and how to go ahead in managing this patient is by this Bayesian law. So if the need for non-cardiac surgery is an emergency surgery, then patient straightway goes for operating room. There is no scope for optimizing. There is no scope for further evaluation. It's an emergency surgery. And then you have to manage the post-operatively. Then you have to manage this patient, stratify this patient on the post-operative and risk factor management. If there is an urgent elective surgery and coronary revascularization happened within 5 years, and if there are no recurrent symptoms, then again this patient goes for operating room and they can be cleared up for the surgery. They can go without any further testing. But if there is a recurrent symptoms and signs of ischemia, then recent coronary evaluation has happened, then on the basis of that we can take the decision, or if the results are favorable of recent coronary angiogram or stress test and the results are favorable, then patient goes for operating room. If the clinical predictors are of intermediate or minor, that we will discuss, but if major clinical predictors are there and the surgery is not very urgent, then definitely there is need for evaluation of this patient, medical management and risk factor modification, further evaluation in the form of coronary angiography in certain patients will be required. So we have to think of these major clinical predictors whenever we are dealing with these patients, like unstable coronary artery disease, decompensated heart failure, ongoing arrhythmias, and severe valvular heart disease. These are the 4 things which counts as a major clinical predictors. If these are absent, then we goes for intermediate clinical predictors like mild angina pectoris, prior MI which has happened more than 1 month, compensated or treated heart failure, diabetes mellitus, or renal insufficiency. If these are present, then we have to look for the what is the functional capacity of the patient. If functional capacity is excellent and patient is low risk surgical procedure, there is no need for further evaluation. Directly patient goes to operating room. If it is intermediate surgical risk procedure and the patient is moderate or excellent functional capacity, again patient goes directly to the operating room. But if patient has poor functional capacity and the surgery is very high risk, then you have to do the non-invasive testing, and maybe on the basis of non-invasive testing, maybe coronary angiogram may be required in this patient. Finally, the minor clinical predictors like advanced age, certain abnormal ECG changes without any symptoms, rhythm other than sinus like atrial fibrillation, low functional capacity, history of stroke or uncontrolled systemic hypertension. If these minor clinical predictors are present, but patient is having excellent functional capacity, again patient goes without any further evaluation to the operating room. If it is intermediate or low surgical risk, again intermediate will go to operating room. Only in high risk procedure with minor clinical predictors, you will evaluate these patients with non-invasive testing. So here high risk procedure, low functional capacity, but the predictors are minor, then also it warrants further evaluation. So that's how you evaluate this patient on ECG on the basis of clinical predictors as well as their functional status. ECG has got definite role, but a very minor role in this patient. But this is a chance where you can identify the patients who are at high risk and you can modify their further course, not only perioperative course, but the further by identifying those patients who are at high risk. So thank you very much. This is the perioperative evaluation. Thank you.
Thank you, sir. If we have queries, we can take it at the end of this session. We now have Dr. C. Narasimhan, sir, on the Zoom network. Sir is going to talk on electrical solution of heart failure. Over to you, sir.
Hello. 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 Hello, can you hear me?
Yes, sir, you're audible, sir.
Oh, sorry. There's some glitches about transmission. I'm sorry. Good morning, chairpersons, ladies and gentlemen. At the outset, I would like to apologize that I couldn't be there in person for your wonderful meeting. Thank you, Dr. Pankaj, Yogesh, and Vinod for your kind invitation. There's an increasing recognition of patients with severe heart failure being referred for transplants or left ventricular assist device. And we need to look at these patients more critically to see whether we can offer something more before we consider such drastic steps. So there's no better way to learn about these. All of us know that tachycardiomyopathy can be due to because of atrial and ventricular arrhythmia, and some of them could be due to dyssynchrony. I'll discuss how electrical disorders results in heart failure. And as I said earlier, all of us in this room are very familiar with guidelines and management decisions, but we take clinical decision making for granted. There is a term where this practical clinical decision making is more important, and that is called as phronesis, practical wisdom. So I'll just illustrate. When you have a person with persistent tachycardia like atrial fibrillation or frequent runs of non-sustained VT, it only causes more and more problems for both atrial and ventricular myocardium in terms of increasing mitochondrial accumulation at the intercalated disc, disruption of intercalated disc, immune reaction mediated by macrophages, which are crowding into these areas of the myocardium, and increase interstitial fibrosis. So what you think is a benign flutter or fibrillation, if left untreated, they lead to permanent structural heart disease. And as a clinician, we tend to think this is a progression of the disease. Okay, I saw him in January and July, I increased the dose of medication, and in next year, I increased the dose of Lasix. And we think it's a natural progression of heart failure without realizing that the atrial flutter fibrillation can lead to permanent structural damage in the myocardium. So let us start with cases. This is why I highlighted the importance of case examples to illustrate this. This is a 13-year-old boy who was evaluated very well, very detailed evaluation with an MRI, echo, and he had a sarcomeric mutations tested. Everything was appropriately done in a center abroad. And then he was airlifted for a transplant because he was not improving despite optimal medical therapy, has severe LV dysfunction, and moderate mitral regurgitation. And on the way to a transplant center, he became very sick and he was moved here. And if you look at this ECG, it's relatively benign looking. However, the clue is the P wave. When a P wave is completely negative without a bifid morphology, it suggests it's coming from the anterior atrium, anterior wall of the atrium, which is either the appendage or high crista. And how does this slow tachycardia lead to heart failure? That's another reason why we need to think about it. Because if the tachycardia is rapid, like 170, 180, patients often complain of palpitations. However, a slow tachycardia like this with intermittent Wenckebach block will cause progressive myocardial dysfunction, and patients seldom complain of palpitations. This tachycardia was localized to high right atrium, successfully ablated, and the sinus rhythm was restored. And you can see after 4 months, this patient had a significant improvement in his cardiac status. And we had to keep him on a small dose of beta blocker and ACE inhibitor. He's now about 4 years down the road and doing well off all medical therapy. Now, Margaret Redfield highlighted this in Mayo Clinic proceedings that these tachycardias are not very rapid but incessant. Hence, they don't have palpitations, but often presents with symptoms of progressive heart failure. In younger patients, atrial tachycardias and axillary pathway mediated tachycardias are common. In older adults, we increasingly recognize atrial flutter and fibrillation as the common arrhythmias which lead to this problem. Now, the importance again is that they are persistent and not very rapid. And increasingly, we have recognized frequent PVCs causes significant calcium overload, and they can be a cause of reversible cardiomyopathy. Again, to illustrate the practical management issue, This is a 59-year-old gentleman who came with ischemic cardiomyopathy. We implanted a CRT, was doing very well for about 4 years. Presence to casualty with hypotension, his tachypneic on NIV, and severe LV dysfunction. Also, patient was already taking amiodarone and apixaban. What you see is an atrial arrhythmia. Because of the tachycardia, patient has lost the benefit of biventricular pacing. Now, one of our residents reviewed a paper on ibutylide and thought ibutylide is considered to be safe in some patients with heart failure. So he gave 1 milligram of ibutylide for this patient. Tachycardia promptly terminated. It's not, let me just, sorry. Tachycardia promptly terminated. However, patient went into severe hypotension, cardiogenic shock, and it took almost about 4-5 days for the patient to come out of this shock because of noradrenaline that was given during the shock period. He had incessant VT, went down to developing renal failure. Ultimately, he survived. What I want you to understand is to go back to basics. This is the dose response curve. As you give a drug higher and higher doses, there'll be an increasing percentage of people who will respond to the therapy. But at a particular dose, the effect plateaus. There is no further improvement. And that is the ceiling dose. But at a particular dose, as you increase a higher dose, the toxicity increases. So certain drugs have a very narrow therapeutic index, margin of safety, and that actually comes down significantly in patients with heart failure. Patients with heart failure develop ion channel abnormalities, which makes them to sequester more calcium in the intracellular compartment, prolongation of action potentials, higher incidence of after depolarizations. Therefore, they are already prone to develop syndromes of ventricular arrhythmia. You just tip the balance by giving some drugs they don't tolerate. There is a higher incidence of hemodynamic instability, like in this patient, or patients may develop a proarrhythmia of VT and VF. And that is the reason this is a very elegant randomized controlled trial where patients come to the clinic with heart failure and atrial fibrillation, persistent atrial fibrillation. And these patients were given amiodarone and beta blocker, and some of them were randomized to catheter ablation of pulmonary vein ablation. Up to first 6 months, you didn't notice. This is the honeymoon period where we think all is well. And the patients, it doesn't show much of a difference. But after that, significant divergence in your survival of patients who go for non-pharmacological therapy of catheter ablation for PVI compared to medical therapy, the best medical therapy. What is impressive is I would like to show the total mortality drops by 40%. This is absolute risk reduction. You don't get this kind of mortality reduction. Heart failure hospitalization drops by 40%, cardiovascular death by 50%, and cardiovascular hospitalization. Total mortality is an undeniable endpoint. And this is a randomized controlled trial which shows that in long term, especially among persons with ventricular dysfunction, catheter ablation is superior to amiodarone and beta blocker. Now, this group from Germany took this step forward among patients who are listed for transplant and left ventricular assist devices. These are patients with advanced heart failure who are listed for transplant and left ventricular assist device. You can see again, the medical therapy mortality is higher compared to ablation group, which is marked in red. At the end of 5 years, you find the patients in ablation group do much better. What is more important is some of these patients were delisted. 10 patients in medical therapy go on to develop LVAD or transplant, whereas in ablation group, only 1 out of this go on to develop. So patients were delisted from transplant and LVAD because of the improvement in clinical settings. And again, primary endpoint of death and hospitalization was almost 80% lower. This test, I think there is a bit of bias, but it looks too good to be true. Nevertheless, the facts are staring. What has made this procedure much easier to do is the contact force. that the EPs use nowadays, because the contact force helps you to improve the efficacy of the lesion and improve the safety of the lesion, whether it's by point ablation or a one-shot device like cryo or a pulse field RF, which is useful. Switching gears, we again, for patients with heart failure, some of them are class 1 and 2. They do very well for years together. All of you have seen on sacubitril valsartan and SGL2, they do well for many years. The only thing in class 1 and 2 patient is an unpredictable risk of sudden cardiac death, especially in patients with old myocardial infarction. Now, this is one such patient who had a survivor of sudden cardiac death. ICD was implanted, had this slow VT going on for days together. Because the rate was below the rate cutoff of the VT detection, it was never detected as VT, and the patient progressively then came to heart failure. The device was reprogrammed, and the ATPs were successful, sometimes unsuccessful, and delivered shocks again and again. Please understand, each shock that the device gives releases some myocardial troponin, which causes myocardial damage. And therefore, instead of surviving from arrhythmic death, these patients die of a heart failure deaths. So when a person gets repeated shocks from the device, their survival progressively comes down, whether it's due to VT or VF. So the risk of heart failure death after an appropriate shock is almost 2 to 4-fold higher among patients where an ICD was implanted for prophylaxis against sudden cardiac death. This patient had a large scar. You can see the left ventricle. What is marked in red is a scar of a very low voltage. And we identify these low target areas for ablation of late potentials, targeted and ablated. Patient had a very stormy period in the ICU, but ultimately pulled through. You can see patient was intubated, ventilated with pulmonary edema, and effusion resolved, and the heart size improved. Patient had features of ALI, acute liver injury, and AKI at the time of admission. So we delayed this till we could stabilize, and then we ablated, everything resolved over a period of months. Second thing is this increasing recognition that patients with heart failure and atrial fibrillation will have atrially mediated mitral regurgitation and ventricularly mediated mitral regurgitation. So instead of fixing the mitral valve straight away by a clip or anything of that sort, this is a patient with heart failure, severe mitral regurgitation, and she was contemplated for high-risk PCI, turned down by surgeons, was referred for LVAD transplant, multiple things were going on. But what is staring is whenever the QRS is very wide, it tells you that one portion of the ventricle is getting depolarized very late, and you need to, some patients may be eligible, some may not be. But you need to look at whether this patient is eligible for CRT therapy. Why is this important? Patient had a severe mitral regurgitation, jet area of more than 13, and she was considered that she will be a non-responder to CRT, and therefore there is a recommendation to go for mitra clip or a definitive therapy like LVAD or transplant. However, I'll probably, let me see whether this plays. This is the initial echo, which shows very poorly contracting ventricle, dilated, and you can see ventricle is dysynchronous, very poorly contracting, and severe mitral regurgitation, which is eccentric, going towards the lateral wall of the left atrium. And this post-procedure echo, you can see a significant improvement in her LV function. MR became trivial, and the patient improved significantly over a period of time. Post-procedure ECG, what is impressive is a reduction in her pulmonary hypertension and severity of mitral regurgitation. So you can see the MR jet came down. There's a progressive improvement in their LV volumes and the dimensions, and patient did well after this. What we have increasingly understood is the balance of filling forces and tethering forces is what determines the mitral regurgitation in several patients with heart failure. When you have a central jet MR, it is related to dilatation of LV. And if you have other characteristics that this patient will be a responder for CRT, please go ahead and implant CRT. There's a good likelihood that this patient will improve with CRT. In patients with eccentric MR, you need to decide whether it is due to pull of the lateral papillary muscle. And that can again result in significant improvement in these patients once it is corrected. Now, putting a device is not well, because if these patients are very sick. You need to implant the device at the site of latest activation. Most of the patients with CRT will respond very well, provided procedurally we take a little extra time. Suppose I implant in a lead in the lateral vein, and that area is a scarred area of the lateral ventricle. I can guarantee you that patient will not improve. If you put it in an area where there is no early activation, late activation of the ventricle, that patient will again not improve. You need to take pains to go, even if it's technically challenging, you need to choose a target where you get the latest area of activation. That is the reason why you need to spend a little time in placement of the lead. And if you do that, you are likely to get a fusion activation of the ventricle, where the intrinsic activation comes in yellow from the His-Purkinje system. RV is getting activated from the RV catheter, and the LV from the latest area of activation. This results in appropriate CRT delivery. However, for some reason, either an atrial arrhythmia or frequent PVC occurs, this synchronization is lost. That is the reason why, as EPs, we are paranoid about atrial arrhythmias as well as frequent PVCs, because they can ruin the benefit of CRT. A patient who has done very well for 4 or 5 years starts having frequent PVCs. It will look very benign on the ECG, but progressively the LV will start dilating again. Now, with the advent of conduction system pacing, our armamentarium for patients with heart failure has significantly improved. Even patients with right bundle branch block, if the PR interval is long, you can consider direct His bundle correction and narrowing the QRS. There is some evidence to suggest 70 to 80% of them, they are likely to improve, especially the RV function. If a patient is a candidate for BIV and a typical left bundle branch block is there, nowadays, instead of His bundle pacing, we directly offer left bundle area pacing. Or if a patient has scar in the septum, it is important to consider lead in the lateral wall of the left ventricle, which can be supplemented by a conduction system pacing. Patients with IVCD are more challenging because the non-responder rates are higher. And in these patients, you need to position the lead at a latest area of activation and try to achieve a fusion activation of the ventricle. And as I said earlier, frequent PVCs result in increasing burden, leads to worsening heart failure. Abolishing the PVC either with pharmacological therapy or catheter ablation improves the outcome in these patients. Never to forget the substrate in this patient. This is a patient with a left ventricle, which you are seeing from behind. Please remember, left ventricle is a posterior structure. You are looking at the left ventricle from the spine, from the vertebral column. And the posterior area of the left ventricle has a large red area, which is an area of a scarring or an inflammation. And when we biopsy this area of inflammation, this is a non-ischemic cardiomyopathy, we could find clusters of granuloma. And because this patient, even if he has a LBBB and heart failure, putting a CRT will not help. You need to address the underlying problem, which is a progressive inflammation. And diagnosis made all the difference in this patient. I think in this brief time of 20 minutes, I don't think I've covered everything, but I would like to thank you for inviting me for this, and would like to thank all my colleagues who are instrumental, all my fellows and colleagues who are instrumental in collecting the data for this. Thank you very much.
Thank you,
Patients
sir.
with heart failure, atrial and ventricular arrhythmias can lead to progressive ventricular dysfunction, and a combination of antiarrhythmic therapies or ablation is required. Patients with wide QRS, physicians, please, whenever the QRS is wide in a person with heart failure, consider either physiological pacing or a cardiac resynchronization therapy, most of the patients, at least 80% of them, are likely to improve in terms of improvement of their morbidity and mortality due to heart failure in these patients. Thank you very much for the patient listening.
Thank you so much, sir, for your valuable insight into the subject. We're deeply honored to have you, sir. Thank you.
Thank you.
We now go over to the next topic, that is acute AF and its management by Dr. Yogesh Kolamkar. Sir is a consultant at Swasthyam Hospital. Over to you, sir.
Good morning, everyone. It's my pleasure being here in front of all senior consultants, expertise in EP specialty and cardiologist. We'll start this topic, acute atrial fibrillation. So all of us know about this atrial fibrillation. It's a very common, simple, and non-life-threatening arrhythmia. But it is an crucial one, and it can put you into a life-threatening situations. So it's complex management. Sometimes it's very simple, but sometimes it's very complex. So coming to a diagnosis of atrial fibrillation, it is a supraventricular type of arrhythmia with uncoordinated electrical stimulation of atria. ECG hallmarks are simple: absence of P waves, irregular chaotic waves, inconsistent R waves, as long as there is no simultaneous third degree AV block. Persistence of AF for at least 30 seconds is necessary for the diagnosis. So you can see an ECG of atrial fibrillation. There are multiple AF patterns. It can be a first diagnosed, sometimes it is called lone AF also, without any structural heart disease. You are getting a first time episode of AF. Paroxysmal, when it is happening suddenly and paroxysmally, within 7 days of onset, it is getting terminated on its own or with medications. Persistent AF that is continuously sustained beyond 7 days, including episodes that are terminated by cardioversion, drug, or by direct DC cardioversion after 7 days or more. Long-standing, if it is continuous AF of more than 12 months duration, when decided to adopt a rhythm control strategy. When we are not adopting any rhythm control strategy, then it is called as a permanent AF. Then coming to the acute AF, this is nowadays a new terminology, or you can say a more focused area. Acute AF is defined as AF detected in an acute care setting or during an acute illness. Is associated with high risk of long-term AF recurrence. Also been referred as secondary AF, but it's not truly a secondary AF. The acute AF may be paroxysmal or persistent, may be symptomatically failed by the patient, or asymptomatic and detected on a incidentally on a rhythm strip or a ECG. Incidence of acute AF, it's increasing nowadays. In medical patient, the incidence ranges from 1 to 46%, varying with severity of sepsis. Sometimes in septic shock, you can see 23 to 44%, while in severe sepsis, it is around 6 to 22%. Depending on the type of non-cardiac surgery, sometimes it is in 3 to 16%. Associated with longer, why this is important? Because it leads to a longer hospitalization, greater morbidity and mortality, higher cost, and subsequent AF recurrences. In cardiac surgeries, if you see incidence, post-operative AF in a setting of cardiac surgery is very common. 32% of patient after CABG, 49% of the patient after concomitant coronary artery and bypass, or with bypass and valvular surgeries. 64% of patient after CABG grafting, and in MVR patients, with high rates of recurrence over a period of time. Then coming to the basic reason for this acute atrial fibrillation, there are some potential triggers under which there are potential substrate. So what are these potential substrate? Either it can be a prior cardiac surgeries which can lead to atrial scars or atrial change in atrial morphology. like atriotomy, cardiopulmonary bypass, prior valvular surgeries, sometimes because of the pulmonary vein automaticity, then atrial scars from chronic underlying process like chronic pressure overload, because of underlying cardiomyopathies, from underlying valvular disease as a part of cardiomyopathy, prior thoracic surgeries like in pulmonary diseases, lung surgeries or lung transplant, pericardial fat pad, it is another risk factor or a substrate you can say. Then there are potential triggers by which, if there is underlying substrate, and these are the potential triggers which lead to the formation of this chaotic activity. So the sources of triggers can be a sepsis, infection, electrolyte imbalance, sometimes a sudden volume loss or a overload, post-procedural pulmonary complication, pericardial effusion or pericarditis, myocarditis. So shift in a autonomic tone, that is also an important thing. Electrolyte imbalance, which is the most common thing. These are the potential triggers. So detection and consideration for intensity of electrocardiac cardiographic monitoring. So this you can see there are multiple scoring systems have been applied in recent times. These are Hatch score initially developed for AF progression, where the AF will progress whatever the AF has occurred in acute situation, or a POF score for post-operative AF have been evaluated as a tool to predict acute AF in hospitalized patient. So these were the scores used, but nothing found very significant. Most commonly used score was a Chadwa score, which is used for anticoagulation, but you can use it for whether there is a probability of having a AF in patients. Second factor you can use is a elevated BNP. If you are having any patient and you are thinking that Charva score is high and patient can probably go into a AF or had a history of AF, now what is the probability to go into AF? You can use these parameters. So you can see multiple risk factors, out of which some are non-modifiable, some are modifiable. Aging, ethnicity, male sex, genetics, these are the non-modifiable. Some are physiological, some are non-physiological. All these are the risk factors for the AF. So coming to the management part, acute management is what are the triggers. Basically, we can modify these triggers, identify and treat. AF management can be done in form of either rate control or a rate rhythm control. Wait and see approach may be reasonable for hemodynamically stable patient or symptomatic patient with acute AF, while acute triggers are being aggressively treated. In hemodynamically unstable patient, immediate electrical cardioversion is the treatment of choice, provided if you are very sure that AF itself is causing hemodynamic instability. So you can see this flow chart. Hemodynamically unstable, if it is he is unstable, then prompt electrical cardioversion. If not, then identify and treat the trigger factors. Assess impact of AF on patient, whether adversely impacting impact from the tachycardia, then better to control the rate. If you are thinking the AV desynchrony is causing a problem, adverse impact from loss of AV synchrony or inability to adequately rate control, then rhythm control strategy should be applied. Acute rate control, less than 110 beats per minute as a reasonable target in hemodynamically stable patient or a patient with permanent AF. Strict target in cases where patient has LV dysfunction or concomitant CRT therapy is there, as already told by sir, or a diagnosis of tachycardia-related tachycardiomyopathy, as Dr. Narasimhan has explained in form of case. In cardiac surgery, rate control target should be less than 100 per minute. So what are the rate control methods? Pharmacological rate control, beta blockers, non-dihydropyridine CCBs, digoxin, amiodarone. Catheter ablation of AV junction with permanent pacemaker implantation is the last step. So coming to the rhythm control, hemodynamically unstable patient, direct DC conversion is the best treatment of choice. Upfront electrical cardioversion strategy or a stepwise strategy with initial pharmacological cardioversion is a good choice, as some of the patient, because of acute triggers or a substrate, they can't be converted into a normal sinus rhythm with the help of DC cardioversion. In such scenarios, stepwise approach is a good approach, whether first you start or load with the antiarrhythmic medications and then go on the cardioversion. Choice of antiarrhythmic medication has to be tailored to the individual patient given the unique safety profiles of each agent. Most commonly used are ibutolide, propafenone, flecainide, and the other amiodarone widely used or widely available. This is a very rare situation where like one morbidly obese patient and having a atrial fibrillation, and we need some AV synchrony. In that scenarios, two defibrillators can be used simultaneously to terminate the AF. So the second part comes is the anticoagulation. The anticoagulation during acute hospitalization. The initial Chadwa score should be used, and according to Chadwa score, you have to decide whether the patient needs an anticoagulation or not. So Chadwa score of more than 2 for men and more than 3 for a female is accepted indication. When early cardioversion is planned, absence of 3 weeks of pericardioversion anticoagulation, a T is must. Whether it is in acute situation, if possible, we should do a T. If not possible, then you have to balance the side effects and the effects. Cardiac the another option can be a CT, cardiac CT, especially with delayed contrast enhanced image, so that you can find out whether there is a clot in LA appendage or a LA cavity. After cardioversion, you need to have 4 weeks of uninterrupted anticoagulation. That is the time period where your recovery of mechanical atrial systole happens. So some of the specific settings and population where we have to manage this AF is emergency presentation of hemodynamically unstable acute AF is managed with immediate DC cardioversion. Aggressive management of acute illness and prompt treatment of triggers remains the cornerstone. Because of the low risk of early recurrent stroke and risk of worsening hemorrhagic transformation, this is a common thing which nowadays we are seeing is in a patient presenting with a stroke and having underlying atrial fibrillation, undiagnosed atrial fibrillation. It is reasonable to delay oral anticoagulation for 4 to 14 days among those with acute ischemic stroke in setting of AF. So this is because of having a low risk of recurrent stroke in such scenarios and worsening hemorrhagic transformation. Of course, you have to consult with your neurologist and to decide whether this is a large infarct or a small infarct. Is a small infarct, we can go ahead with the anticoagulation as early as possible. If you are thinking there are worsening, there are chances of worsening in form of hemorrhagic transformation, then better to avoid for 4 to 14 days. Then in cases hyperthyroidism, recently I also had undergone through this case. So beta blockers will be a great choice with anticoagulation. Instead of directly go, because hyperthyroidism it itself needs some time, at least a week or to manage the hyperthyroidism. So during that period, you need to have a rate control rather than rhythm control, because rhythm, if you go for a rhythm control with the help of any antiarrhythmic drug or a cardioversion, the patient can again go into a atrial fibrillation. So hyperthyroidism, another thing is hyperthyroidism may induce hematologically prothrombic state. So anticoagulation is, if your Chadwa score comes into a range, then better to go ahead for anticoagulation in hyperthyroid state. Non-cardiac surgeries where volume repletion, correction of anemia, anticoagulation depends upon the bleeding risk. Cardiac surgeries, prophylaxis with beta blockers or antiarrhythmic drug depending upon the risk of AFib and side effect profile of amiodarone. If patient is prone for atrial fibrillation, has a past history because of some ischemic component, because of uncontrolled hypertension or something, then in such scenario you can go for beta blockers or amiodarone. Other agents investigated for cardiac surgeries are colchicine and ACE inhibitor. Nothing found very promising. A front left atrial appendage closure or a ligation or a mace procedure for a permanent AFib in patients who are going for a cardiac surgeries, especially those are going for a valvular surgery, because they mostly go on a pump, and in such scenarios these surgeries can be done. Acute AF after cardiac surgery with rate control is the initial strategy, reasonable about less than 100, because most of the time they are temporary, they revert on its own. Data related to anticoagulation for AF after cardiac surgery are very limited. If atrial fibrillation is lasting for more than 24 hours, consider anticoagulation for at least 6 weeks. So some of the centers they are following this, some of the centers they are not following in view of, because the surgeons are more concerned about bleeding problems. So 6 weeks with single antiplatelet in cases of CABG, cardiologist also will think of whether to go for that or better to be on a dual antiplatelet instead. Then coming to the similar kind of arrhythmia is atrial flutter, follows the same principle as atrial fibrillation management. Ibutolide and dopilide are the more effective than amiodarone because up to 50% of patients with atrial flutter can found to have incident AF after atrial flutter. So this is very important to manage. Actually, rate control strategy is very good as compared to a rhythm control strategy in atrial flutter, because if you control the rhythm, after that there is more possibility that patient around 50% of the patient have tendency to go into atrial fibrillation. Second thing is catheter ablation is a good choice for atrial flutter as if you compare with the atrial fibrillation management. So coming to a longer term management, what if after managing your acute situation, what about the longer term management? The 5-year AF recurrence rates were around 42 to 68%. In cases of acute medical illness, in non-cardiac surgery is higher, and in a cardiac surgery is very higher. Further management of AF, anticoagulation and consideration monitoring and guiding and appropriate risk factor modification are the key aspects. Basically, you have to find whatever the acute triggers are there, what are the substrate, how you can modify those substrate. The optimal frequency, duration and modality of long-term monitoring for patient with acute AF still remains unclear. So why the long-term management is very important? Because of all these complications related to AF. So if you can say AF related outcomes, as such AF itself doesn't lead to a death, but its complication, yes. So it increases the mortality by 1.5 to 3.5 fold. Stroke risk by 20 to 30%. That is a huge number. LV dysfunction or heart failure in 20 to 30% of the cases. Cognitive decline or vascular dementia. You can see this is also around hazard ratio of 1.4 to 1.6, irrespective of a stroke history. Some patients have depression, impaired quality of life, and recurrent hospitalization in 10 to 40% of the patient. So the second reason for long-term surveillance or long-term management is AF begets AF. Because as AF persists, progressive changes and atrial remodeling can occur, resulting in atrial dilation and fibrosis that may preclude the restoration and maintenance of the sinus rhythm. So if you come to a summary of management of acute AF, there are 3 A's in acute management. You have to see for acute triggers, manage those triggers, then go to the AF control in form of either rhythm or rate control. Third is anticoagulation, whether that is needed or not. Then transition of care, your whatever the patient was admitted for, you have to manage those things, and in long-term basis, you have to see for 2 A's and 2 M's. A for AF control, either rhythm or rate, and then anticoagulation, whether patient fits into a criteria, then monitoring and modification of the substrates. Current guidelines recommend long-term anticoagulation of patient with Charva score more than 2 for men and 3 for women, with preference for DOACs over vitamin K antagonists. Comprehensive risk factor modification like with weight loss, blood pressure management, glycemic control for diabetes, sleep disorder, breathing management, alcohol reduction, tobacco cessation, and of course exercise plays an important role. So coming to the end of topic, acute AF is associated with high risk for long-term AF, warranting clinical attention during acute hospitalization at transition of care over a long-term and follow-up. Acute management of AF occurring during hospitalization requires a multi-pronged approach. Acute rate or rhythm control strategies should be individualized with consideration of the patient capacity to tolerate the AF versus rhythm control. Indication for anticoagulation based on substrate with feasibility and timing of anticoagulation based on patient's bleeding risk. Given the high risk of AF recurrence in patient with acute AF, clinical follow-up and extended heart rhythm monitoring are warranted. So there are multiple complications of AF. Because of that, the AF it should be monitored well. Because AF behaves like a diabetes and hypertension, like a chronic diseases. In initial phases, they didn't cause any much problem, but at later dates leads to a much bigger problems which are difficult to manage. Overall management of acute AF addresses substrate and triggers. 3 A's of acute management and 2 A's and 2 M's of long-term management. So coming to the main case scenario, some of the cases which are real life cases, and we also find difficulty while managing these cases. Because telling a theory is very simple, but when it comes to the practical is very difficult. As Dr. Narasimhan sir told, the practical knowledge or practical wisdom is different from whatever we know or whatever we read from the books. So you can see this is a first case, 67-year male, diabetic, hypertensive, fair LV function, underwent a CABG. Post CABG was on NORAD support of 2.6, very minimal dosage. After 6 hours of surgery, patient developed atrial fibrillation with rate of 160-180 per minute. Now the blood pressure is borderline. What should be the management, and what about anticoagulation in such scenarios? So if anyone from audience would like to contribute. So here 3A's, if you come, there's a acute triggers or a substrate is of course there. Patient is diabetic, hypertensive, and underwent an CABG surgery. So these are the substrates. Now coming to the triggers, why it has been triggered, either related to volume decrease or volume overload. This can be one possibility. Second is your electrolyte imbalance, because this is a post-surgical patient. Third is a sympathetic tone, because now it's been 6 hours after the surgery. The patient must be weaning off from the ventilatory support and trying to come out from the ventilator. Third is a minimal dose of, or whatever dose, but the patient is on a noradrenaline, which is of course a sympathetic stimulation for the heart. So these are the triggers. Now how we go about these triggers? So try to find out whether there is a volume overload or not. If volume depleted, depending upon his IVC and central venous pressure, we can replenish the volume. Second is electrolyte imbalance. Check for most commonly the potassium. You can see if it is a hypokalemic or something, then you can correct that hypokalemia. Third is about this NORAD support. Now borderline hypertensive, no one will touch that NORAD till the patient comes goes into some mean pressure of around above 80. So what should be the management here? Most of the time in cardiac surgeries, it is a temporary AF, it will be a paroxysmal. It will last for a few hours and spontaneously reverts back to a sinus rhythm. What we can do is wait and watch policy here. Try to control the rate with the help of either antiarrhythmic drug or with the help of some beta blockers. The scope for beta blockers here is very less. So we can go ahead with the amiodarone, which is a commonly used and easily available medication. With that, we can control the rate. And if rates get controlled, patient will slowly come out of the situation. Most likely this patient will come into a normal sinus rhythm within a day or within a 12 hours of period. And once his sympathetic tone is decreased, all things are settled, his NORAD will be settled out and his AF will get terminated. If this atrial fibrillation goes beyond 24 hours, then we'll plan for anticoagulation, otherwise no anticoagulation for him. Now this is second patient, obese, 110 kgs, known hypertensive and non-alcoholic liver cirrhosis, admitted with shock and AFib of rate 180 to 190 per minute. History of melena since last 10 days. Outside hemoglobin was 5 and echo found to have echo to be a normal, shows a normal finding except mildly dilated left atrium or mildly increased left atrial volume. So how to manage this type of critical patient and what should we do about the anticoagulation? So looking at the history of melena and hemoglobin of 5, anticoagulation is out of question. Second thing is how will you manage this patient, because he is already in a hypotension or in shock. The shock might be because of a hypovolemic shock, because of his history of melena. He must have lost a lot of blood. Then only his blood hemoglobin coming out to be a 5 or 6. He is 110 kgs. So looking at this condition, here the triggers are of course a hypovolemic shock, substrate is a big, obesity, hypertensive, diabetes, underlying little increased left ventricle, left atrial volume. So those are the substrate. But what to do about triggers now? We can't replenish his hemoglobin from 5 to 10 in a day or in a day or two. We need some time to replenish that. What we can do is we can avoid further decrease in the hemoglobin by doing some intervention like upper GI scopy and found out where is the bleeding point, and you can clip that bleeding point, or you can manage things simultaneously. You can put you can give him some blood, and if the patient is showing deterioration, then better to try 1 DC cardiogen in such scenarios, because even though there is a high possibility that even after DC cardioversion, if sinus rhythm comes, for how much time the sinus rhythm will be there, we don't know. But in such a critical patient, we should try at least once or at least 2 times DC cardioversion, because that is the way this patient can be managed. Otherwise, there will be a loss of AV synchrony. The hypotension can't be treated. He will be initially he will be 1 or 2 PRCs will be given. With that PRC, if blood pressure comes, that is well and good. If his blood pressure doesn't come, then someone will be there to put him on some inotrope supports. And once the inotrope supports will be there, again he will go into a atrial fibrillation with increased rates. So such patients coming to the emergency, try defibrillation without looking at whether patient needs an anticoagulation or anything. That is the best possible answer. Am I right, sir? Because such scenarios will need some discussion with seniors also. It's not so simple to treat such scenes. This patient we are not able to resuscitate actually. This patient after 12 hours has died because the bleeding point, we could not find a bleeding point, or whatever the bleeding point we could observe, which was not able to deal with that. So this patient could not survive. After around 24 hours of hospitalization, he died. Then coming to the another patient, 78 years male, diabetic, history of CABG, presented with acute MR. Query, it was a rupture chordae related to myxomatous mitral valve. Maintaining hemodynamics was in frank pulmonary edema, managed with diuretics and NIV support, but goes into atrial fibrillation with high ventricular rate, which leads to pulmonary edema and decompensation. So whenever this patient used to go into atrial fibrillation, was losing his AV synchrony, and he has underlying substrate as an acute MR. Whether it was a days old MR, it was not like a very acute situation. Otherwise, would have been in a very much in a hypotension rather than a normal hemodynamics. So how will you treat this? This is a more of a simpler compared to the previous case. Here, antiarrhythmics and rate control medications plays an important role. AV synchrony, whenever he is losing AV synchrony, he is going into a heart failure. So you can manage this with rate control initially. If rate control is not, if he is not been settled on the rate control, then better to go for a rhythm control in form of antiarrhythmic drug or DC cardioversion if he is having hemodynamic instability. And of course, treat the substrate as soon as possible. So another last example, 60-year female DCMP, query secondary to myocarditis with severe LV dysfunction, EF of 10 to 15%, admitted with CCF with congestive hepatopathy and on inotrope support. Now having AFib with high VR of around 150, 160. So again a very complex situation. So whether this hypotension, because this is a chronic, the patient was known dilated cardiomyopathy, decompensated by atrial fibrillation. The substrate is there. What is the trigger here? We don't know the trigger. Yeah, as from the history, it looks like DCM dilated cardiomyopathy was not properly managed, was not on a guideline-directed medical therapy. He was not in a compensated state, which lead to a multiple other organ dysfunction like liver, kidneys, and which might have triggered the atrial fibrillation, as they are already a subset of dilated cardiomyopathy. So this patient actually, if it is a high, patient is in hypotension, better to go for a DC cardioversion, at least an attempt. If patient comes into sinus, treat the other problems, like if there is a kidney function, try to check for an electrolyte imbalance, correct those electrolyte imbalance, try to achieve diuresis in a compensated manner with the help of some inotrope support if needed. Better to avoid in such situations. And you can see there is a hepatopathy also. So in such scenarios, and which antiarrhythmic drugs you will use, there are not a lot of scopes for antiarrhythmics here. Amiodarone, which is widely used, you can use it, you can't use it looking at congestive hepatopathy. If it shows some improvement over a period of time, then you can add amiodarone with risk. And what else? The other antiarrhythmic drugs, looking at the dilated cardiomyopathy and such scenarios, of course, that is like you are putting a knife in someone's chest. So again, DC cardioversion is the best choice for here as at a initial management, and followed by the other comorbidities. Thank you very much for please. Thank you.
Thank you, sir, for your notable takeaways. We can have a few questions if there are any queries from the audience. Do we have any more queries? We skip the tea break and go over to the next session. It is overview of antiarrhythmic drugs by Dr. Saurabh Deshpande. Sir is an MBBS MD, DNB, DM cardiology with a postdoctoral fellowship in cardiac electrophysiology, heart failure and pacing. Sir has a good teaching experience. Sir has many awards and honors to his credit. The honors are from KHRS Young Scholars Quiz Competition, the Cardiology Quiz at the annual conference in Kerala, and many other prizes and honors to his credit. Over to you, sir. Welcome, sir.
Thank you so much for all the introduction. At the outset, I want to thank Dr. Harkut sir for giving me this opportunity. I was on the same dais last time with all of you, and happy to be here again. I want to say that this today being the Mother's Day, so happy Mother's Day to all the mothers in the crowd. So it's an auspicious day or the place for me because my mother was from GMC Nagpur, so I'm lucky to be here on this particular day. So coming to the topic proper, my topic is very boring. I think many of you might have skipped and they still skip this topic every time it comes. At the outset, I just want to ask, what is your favorite antiarrhythmic drug? Can I have some names? I was afraid to hear that word. So through this 15-20 minutes, I will try to dissuade you from giving a medron. Hopefully, I will be able to achieve it. So we'll discuss what are the arrhythmias, how the mechanism actually is there, and it can help us. So you've heard senior electrophysiologists speak about all these arrhythmias since morning. Some complex cases which may or may not come to you, but then the simple ones we day-to-day experience in our life, how to manage those with the common antiarrhythmics which are available nowadays. The armamentarium is not increasing, sadly, but whatever is there, we can use it. So this is how everybody, all of you are aware, there is something called as bradycardia, something called as tachycardia. Whatever goes below 60 is bradycardia by definition. Whatever goes above 100 is tachycardia. Then there are multiple causes for it. If it happens at the sinus level, AV nodal level, it is a different disease. Sometimes it happens at both the levels, which is also binodal disease. If the tachycardia happens above the AV nodal level, it is supraventricular. If it is below the AV nodal level, it is ventricular. So diagnosing this on an ECG many a times helps us in strategizing our further line of management in terms of antiarrhythmic agents or something else if the patient requires. You need not always diagnose the mechanism of arrhythmia, but it is helpful many a times if you can do it. So two common things are that there is some problem with the starting of the impulse, that is impulse formation, or the conduction of the impulse from upper chamber to lower chamber. So there can be automaticity which can be altered or normal, abnormal, or there can be some rhythm, the conduction disturbances like re-entry. So re-entry requires one circuit with a block, another circuit which is available, so that will cause a re-entry in the local area or a wider area as the condition is. There is conduction block, we'll be I think hearing about conduction blocks later on. There are accessory pathways. So all these are abnormal transmission from upper to lower chamber, which may require management at certain level. You have seen these graphs sometimes before or as well. I just wanted to highlight the difference in the APD, that is action potential and action potential duration, all throughout the cardiac chambers. So at the, just a second. So we have the SA node. Here the action potential is slightly different. It will have spontaneous depolarization, then go up, and then everything will work spontaneous. That is why we call it a pacemaker site in the heart. But then everywhere else, it is almost similar to the myocardial action potential curve, slightly different in the AV nodal area. So this is how it correlates with the ECG as the impulse goes from sinus node to the distal most part of the heart. This particular thing becomes important specifically in prescribing any antiarrhythmic agent because they will act at certain level in this particular action potential. So this is the commonest diagram you might have seen everywhere. Hundreds of times you have read these and nobody remembers it. Frankly, I also don't try to remember it so much. But then you should understand some of the, what you can say, electrolytes which play an important role at certain places, because that is how you can treat those patients very well. Like the sodium is more important early on in the cycle. So if you want to remember it easily, whatever the sodium and calcium is mainly in the part of the early depolarization part of it, and repolarization part is taken care of by potassium. That is the easiest thing which you can remember. Rest of the things can fine tune later on. This is how the things happen at sinus nodal level. So here the difference is the IF current, that is the funny current. That is the one, the conduction, ion conduction channel, which is there specifically at SA node, and it is sometimes found in the atrial myocardium as well, but then we don't, we generally specify it to the SA node, and that is how some of the targeted therapies are coming into picture, which are acting only at the SA nodal level. Where do you need the antiarrhythmic agents? You need either for acute management. I think Dr. Yogesh has very well shown you how the acute management goes, and then how the chronic management goes for atrial fibrillation. Similarly, you have other arrhythmias for which you require acute termination or chronic for maintenance. So many of the arrhythmias, barring some of the arrhythmias like atrial fibrillation, give you very high satisfaction level once you use these antiarrhythmic agents in an acute setting. But once you go to the chronic part of it, you require specialized management. You need good expert opinion to go ahead with the antiarrhythmic agents which are to be used. Sadly, the development of antiarrhythmic agents has not gone hand in hand with the EP development or the device development, but we still have a good amount of medications at our disposal today as compared to what we had in the 70s. There have been multiple classifications for antiarrhythmic agents. There is no point in dwelling into the details of it. The most practical thing is what we have all read about, is the von William classification with the Sinks modification. This again is a very complicated thing. You don't have to remember all of it. Just remember the channel and the drug if possible, because those intermediate association, fast association, slow association is very difficult to understand. Now, to simplify it slightly, I would like to use one analogy. Class 1A agent is, you might not ever use in your practice, quinidine and procainamide. Quinidine, one, it is not available, procainamide is not available. So let that thing slide. It is going to be available soon, but then we'll get to that later. But then class 1B and 1C that you use, I think, day-to-day practice very commonly. So one thing is to remember is 1B agents are fast association and dissociation of sodium. So they will act on open channels or the depolarized channels. So they will be fast. So if you want to remember, these channels are more used by senior interventional cardiologists like Harkut sir. So if you remember fast, the interventional cardiologists will be using. So these are lignocaine, mexilatin, they are using it very commonly. We as electrophysiologists are very sedated people. We want things to go very slowly and as casually as possible. So we use more slow medications like the flecainide, the propofenone. So if you see us more using these medications. So if you want to use that analogy, if it helps you to remember, good. Then the other things, I think you all have used the beta blockers, the calcium channel blockers. You all know about them. You know your most favorite medication, which is amiodarone, and its congeners are there. There are other fellows who are there with its sotalol, ibutylide, dofetilide. There are some direct inhibitors like adenosine digoxin. They are very important in certain situations. So I'll be touching upon those as well later on. Coming to class 1A agent, as I told you, they are not available in India. So one of the agents which we find in our practice is diazopyramide, and there is a very specific indication for it. You use it in HOCM, that is hypertrophic obstructive cardiomyopathy, many a times, and vagally mediated AF, it is very difficult to diagnose, but if you can diagnose it, that is one of the situations where you can use it. The caveat, so I have tried to compile it from multiple sources. later on you can go through the details of how many channels it acts on. It may not be practically possible to remember everything. Just remember these class 1A agents increase the risk of QT prolongation and torsade. So whenever you are using it, always monitor QT, corrected QT, and then go ahead with your continuation or modification of the therapy. One caveat to use these 1A agents is whenever you are giving it for atrial fibrillation or flutter, there is a chance that the AV nodal conduction might get enhanced with the use of these medications. So you need additional AV blocking agents sometimes along with these particular agents, specifically when you are treating atrial flutter and fibrillation. That's very important. Class 1B agents, as I told you, they act fast. So they act on the open channels, or open channels means the depolarized channels which are there in the sodium. So the highlight of this particular genre or the group of medication is the APD is shortened. What the APD means, the action potential duration is shortened. So the drugs which we heard before in class 1A, they prolong QTC. These particular agents counteract that with decreasing the QTC. So this is very important. There are very few medications who do it, and these are one of the practical solutions. Lignocaine, all of you are aware, it's the main problem with lignocaine is the CNS side effects, and many a times the lignocaine is given in acute situation where the patient is under deep sedation or intubated or in a very critical state. So it is very difficult to diagnose these CNS manifestations. You have to be aware of them. So whenever a patient is on lignocaine and showing some improper response which is not in line with your clinical findings, some CNS symptoms are there, you should always think about lignocaine toxicity. Why? Because lignocaine has a very small therapeutic range. It has to be between it is very difficult to do the levels, but if you do it, it is 0.5 to 1.5 milligram per DL, microgram per DL therapeutic range. So that is a very, very narrow range. That is why these CNS side effects are common. They are not appreciated well, but then that they should be looked out for. The same thing is there with mexiletine, but it is at a very lower level, so they are relatively safer as compared to lignocaine, and it has an oral form, so you can give it on discharge as well. So you all are aware lignocaine is given for VF in specifically ischemic settings, because ischemic setting is where the depolarized channels are high, so that is where it will act properly other than the chronic setting. So lignocaine and mexiletine in itself does not have a very high potency to treat VT-VF, so it is generally used as an add-on drug to class 3 agents, which is your favorite drug, which is amiodarone. Now the class 1C agents which are there, which are, as I told you, they are more used in cases of where the arrhythmia management goes to the atrial side. So the flecainide and propafenone, both are available in India. I think all of you might have used them. The thing which has to be remembered is the structural heart disease has to be ruled out. So what do we mean by structural heart disease? We rewind back to the first lecture given by Malav. He has very beautifully showed you multiple places where you can find scar. So if you find scar, please don't give these medications unless and until you are definitely sure that this will not cause harm. If you give them these medications, there are high chances that these can cause side effects. And diagnosing flecainide or propafenone toxicity is slightly difficult, so it is try to avoid it in those situations. Again, as we discussed with 1A agents, these also can enhance the AV conduction if you give it for atrial flutter or fibrillation. So any time you are giving flecainide or propafenone for an atrial fibrillation or flutter, please add it with some calcium channel blocker or a beta blocker, which will block the AV node and it will decrease the chances of this particular situation. Beta blocker, I will not dwell into detail. All of you are aware it is a negative chronotropic action, inotropic, it prolongs the AV delay, and main uses AVRTs that you all see every day. Flutter fibrillation, if you are planning a rate control, this is the first drug to go for. There are some other uses as well, which I will not highlight here. The common drugs which are used are propafenone, if you want to go for a non-selective agent, metoprolol or esmolol, which is the faster acting out of the lot. There is something, so there is a bisoprolol, I think many of you might have used that. The potency is slightly higher than other three agents which I have discussed. Class 3 blockers, It is potassium channel blocker. It increases the refractoriness, so it increases the APD as we discussed in class 1A agents. It can cause QT prolongation and torsades. Now, the tendency of causing torsades is slightly different for multiple agents which are in class 3, out of which the safest is amiodarone, which is like the crowd favorite. But if you go to the other side effects of amiodarone, like the extracardiac, I think all of you are aware. I'm just highlighting the same thing: pulmonary fibrosis risk, the risk of corneal microdeposits, the thyroid dysfunction, the photosensitivity, and the neuropsychiatric side effects. Most of the times we tend to ignore those in patients. We try to treat those side effects whichever are there with other medication or other line of management. Rather than that, you can just skip giving amiodarone if you have other possible drug available in that situation. So for example, atrial fibrillation, treating with amiodarone directly without trying to give other agents which are available and which are safer as compared to amiodarone, it is that is one decision that should be taken properly. Sotalol it is a good agent, but it has a higher chances of QT prolongation and torsades because it does not have the protective action which amiodarone has. Like amiodarone can block the class 2 and class 4, the beta blockers and the calcium channel blocking effect, which decreases the chances of causing torsades in case of amiodarone therapy, which is not there in the sotalol treatment. So that has to be remembered. All other things I think you all are aware about. Ibutilide use, I would like to highlight, has to be increased in the population where you are planning to give cardioversion, because that is one drug which has relatively lower side effects, or I would say if you manage the ibutilide infusion properly, then the side effects can be managed very well. One thing to always remember is don't give ibutilide without checking QT, without checking magnesium levels. Always magnesium has to be checked in ibutilide. If you don't have the facility, just give magnesium before starting the ibutilide infusion, and then then give ibutilide infusion. The dose has to be given properly. So the proper dose is 1 mg for more than 60 kg, or less than 60 kg you have to calculate it according to the weight. But it has to be a proper dose, and we can give ibutilide maximum of 2 times with in between duration of 10 minutes, and always giving before the second dose, always look for the QTC and other side effects if they are there. So this particular agent use should be increased for atrial fibrillation rather than directly going for amiodarone therapy in an acute setting. Dofetilide is not available in India, but the usage is almost similar to ibutilide, but it can be given oral, but we sadly don't have that option in India. Now the class 4 agents are calcium channel blockers. All of you know about them. They are very old drugs. I think one of the earliest agents which were used for arrhythmia. But the only problem is we cannot give these agents in patients who have LV systolic dysfunction, because all the trials which have been done show that heart failure is exacerbated in cases if we give calcium channel blockers in this particular situation. Now the other uses in AF, we can do the rate control with it. The 2 agents which are not classified in either of the 4 classes, I think this particular adenosine injection part we had discussed last time as well. Can I hear it from somebody from the audience? How do you give adenosine? I showed it for some time, but then, yeah, anybody? Okay, then? Sorry, can we give the mic to somebody in the crowd? Yeah, central line then. Whoever, it's just to understand the एग्जाम नहीं चल रहा है. It is just a discussion. Sorry? So you have put a central line. Say you don't have a central line. You have. Sorry? Okay. Yeah. Okay, so that is what happens generally in the acute care setting. Thank you so much for that answer. That is what happens in our acute care setting in emergency. We directly put an IV line and directly give adenosine and then flush it later on. The step which has to be added to that is we should confirm that the IV line which has been put is blood free. If you give adenosine in a blooded IV or intracath, the adenosine will get degenerated there itself in the intracath. It will never reach the blood where you want it to reach. So always flush the line up before giving adenosine, clean that whole area from blood and then give adenosine. So many times what happens whenever you hear that adenosine has failed, the adenosine has not failed. Actually the method by which it is given is failed. So always remember to give it properly. If it is given properly, it actually helps you a lot. The adenosine is like one of the drugs which can be given anytime. In a hemodynamically unstable person also you can give it. So that is one good, great advantage. I think Dr. Yash Lokanwala sir had published one very good article last year on usage of adenosine. If you have, can go through it. It's a very good article. So this thing, one step has to be added. It will help a lot. Always tell the patient that patient will develop experience some bronchospasm. It will be transient. I think 90% of our patients will experience that. So always tell them that because they will be apprehensive towards it. And adenosine dosage are not additive. So it is not like the first 6 mg has failed, that means second 6 mg will be useful. No. So when you go for the second dose, give it a 12 mg dose. Because it is not 6 plus 6, 12. The adenosine has a half-life of 10 seconds. It will go off within the time you give the injection itself. So always if you have to give a second dose, give a higher dose, but beware whenever you are increasing the dose, there are higher chances of AV block and you have to be ready for it. So always remember how to give adenosine, how to increase it and how to pacify the patient while you are giving adenosine. Usage are multiple. I will not highlight all those. We all use it for SVT termination very commonly, but there are other places where it can be used, and that's why I said that is one drug which is very safe in giving, it can be given in any arrhythmia situation. Digoxin has taken a back seat since a very long time, specifically since DIG trial results, there have not been any trials on digoxin. But nowadays in our the protocol for heart failure management or atrial fibrillation management, whichever are the places where you can use digoxin, has gone very low because of the, again, low therapeutic index of the drug, and it does not add to mortality benefit. So it will be one of the last line agents you can use. You all are aware about the side effects, which it can cause either tachy or bradyarrhythmic side effects. Bradyarrhythmic are more common obviously, and reverse check mark sign and mustache sign and multiple names are there just to find out the digoxin toxicity has happened. So digoxin level you can do, many labs it is there, but it should be done whenever you are planning a longer term digoxin therapy. Always beware of the renal functions, because that is one place where digoxin toxicity happens very, very fast. So if you think the patient has renal dysfunction in acute or a chronic care setting, please modify the medication accordingly. There has to be a drug-free period of 2 days. That is how we give 5 days drug and 2 days drug holiday. There are some papers where they say that rather you give a lower dose on all 7 days, but then better to give a drug-free holiday, drug-free days, so that the toxicity can be prevented. This is the proposed new classification. What the scientists or the doctors or the electrophysiologists, whoever is bringing out these classifications, they are just trying to make more practical classifications, but they are more in detail, so they are very difficult to remember, so that you can just go through it. This is published in 2018. The Sicilian Gambit classification is similar to this. It also has some practical implications, but it's complicated to remember. Now, we should be aware that whichever drugs you are using as anti-arrhythmic, they can actually have a pro-arrhythmic effect. The most common thing, I'll try to finish in 1 more minute. The most common thing which I see in the day-to-day practice is overuse of ivabradine. Now, ivabradine is one drug, I agree it's a good drug, it has less side effect profile, but if it is given in a situation where the patient has a substrate for atrial fibrillation, now substrate is very nicely shown by Dr. Yogesh in his talk. So what is meant by substrate? So if patient has a substrate, you are actually pushing the patient into atrial fibrillation while giving ivabradine. So always remember, if you have no other choice, okay, give ivabradine, but that should not be the first drug. Specifically what has happened since COVID, many people are presenting with different types of tachyarrhythmias, sinus arrhythmias and sinus tachycardias, and this has been overused since the COVID time. So we have to be aware about this situation where you are not inducing atrial fibrillation with the use of ivabradine. Other things I have discussed before, like torsades with class 1A agents or class 3 agents, there is a chance of 1:1 AV flutter with class 1C and class 1A agents. And you all are aware about the blocks. I need not tell that, because whenever you give an AV blocking agent, there is always a chance that you can induce an AV block, type 1, type 2, or depending on the situation. So this, I just wanted to highlight the atrial fibrillation part of it. Management, I think these are the guidelines from EHRA. So there are narrow complex, wide complex tachycardia guidelines. Most of the guidelines always start with the vagal maneuver whenever possible, and then go on to the antiarrhythmic agents. So most common antiarrhythmic, safest antiarrhythmic agent specifically in SVT is adenosine. So just it can help you terminate, or it can sometimes help you diagnose the tachycardia which you are going to treat. Now wide complex is a slightly difficult subset to manage, many times difficult to diagnose, but then whenever you have diagnosed it well, specifically in the pre-excited SVT or a setting where you have normal ejection fraction, try to avoid amiodarone as the first line of agent whenever possible, even in wide complex tachycardia. So giving flecainide, again, it is a difficult diagnostic decision or therapeutic decision, but if you have other agent like sotalol, try to use that first before giving amiodarone whenever you know that there is one of the options. Of course, whenever you have LV dysfunction scenario, which is very common in acute setting, you don't have any other option but to give amiodarone. But DC cardioversion, as has been highlighted by Dr. Yogesh multiple times in his talk, that is one place where you can actually prioritize DC cardioversion before giving amiodarone. Now, important part to remember is these all things which are written here are useful only for acute termination of that particular tachycardia. So whenever you are dealing with a chronic management, you have to add an agent. So one of the agents in poor LV function is amiodarone. So there you don't have much of an option, but whenever LV function is normal, you have options. AV and RTs, I think all of you are aware about these guidelines. Give some medications if patient is not willing for ablation. Otherwise, catheter ablation is one of the things which should be done as early as possible, because that is lifelong benefit to the patient. Same thing happens with the AVRT. Catheter ablation everywhere has been preferred. Whenever you have a pre-excitation syndrome, that's a difficult topic to deal with in one line, but yes, you have asymptomatic pre-excitation, most of the times catheter ablation is not required, nothing is required, no medication will be required other than certain specific situations. Focal atrial tachycardia are difficult to diagnose on ECG per se. I think one of the cases which was shown by Narasimhan sir was very nice elucidation of that particular arrhythmia. Whenever you have hemodynamically unstable patient, don't think about anything else, just shock the patient out of the rhythm as early as possible. If you can rule out the clot, that will be the best thing possible for the patient. And rate regulation, beta blocker CCBs, and long-term management, again, if you see in the guidelines, everywhere, class 1 is the catheter ablation whenever possible, because that helps the patient lifelong in many of these type of tachycardias. I will not go into this AF because it has been dealt with very well in the last talk. I just want to highlight whenever you have failed all the drugs, always think about APS RFA. That is one thing which is developing very fast, and in the near future, maybe within next year, we will get a safer technology, I would say, for ablation of atrial fibrillation, which might help many of the patients. So in summary, most of the antiarrhythmic agents, as I showed in all my tables, have complex effects, multiple channels they act on. You don't have to remember everything, but then remember the highlights of those agents. Please beware of the pro-arrhythmic agents. I have tried to highlight it as much as possible. And a particular arrhythmia specifically requires a specific medication at that point of time, or a sequential use of medication, as in case of atrial fibrillation. Depends whether you are using an acute or chronic control. Thank you so much for your patient hearing.
Thank you, sir, for simplifying such a complicated topic. I would now invite Dr. Malav Jhala, sir, for the talk non-ischemic ECG and echo changes and its clinical correlation. Over to you, sir.
Yeah, so after a very good talk by Saurabh, before I start my talk, I like to apologize for two things. First, we are subjecting you, me and my colleagues are subjecting you to this without a coffee break, and you guys are doing very good, I can see. I can see a few very awake and alert faces, that's a good thing. Of course, feel free to have coffee at the back, because we are going to switch gears. We are going to go from only ECG to some more imaging, that is 2D echo. And the other thing that I'm going to apologize is all that I'm going to say after this, because we spent a decade talking about what ECG changes come in MI, in ischemic heart disease, and how you should be watchful. And now that we all are very masterly in trying to diagnose MIs on ECG, we are now talking about that's fine, but now you have to look at the non-ischemic etiologies of them as well, and the ECG patterns may be deceiving. So it's relatively unfair on our part to tell you this, but then what is common with non-ischemic etiologies is that they predate the ischemic event in a particular patient. They may be associated with an ongoing ischemic change, and they may come in a patient who was a prior ischemic heart disease patient on follow-up. That means that though the most common cause of cardiomyopathy may be ischemic heart disease, but the non-ischemic subsets are the ones which are now increasing, and they need a little bit more thoughtful understanding of the clinical scenario in corroboration with a good ECG and an echo correlation. A 2D echocardiogram is equivalent to a stethoscope today, and the reason is it gives you real-time information. A CT or an MRI is a snapshot. So when you have a real-time movie in front of you, you are much more wiser. Of course, how you do the echo and how do you interpret it is something which requires a little bit of more experience, maybe 2 or 3 senior opinions, 2 or 3 co-worker opinions, but it is important and it gives you vital information. So we'll go directly, a few housekeeping slides, and then we'll go directly to the cases. So as we discussed, cardiovascular disease is the most prevalent disease worldwide, and it forms a sizable proportion of emergency visits. There is a significant proportion of so-called ST elevations which subsequently turn out to be that they didn't have an MI or they didn't have a significant stenosis. They underwent an angiogram and the angiogram was deceivingly normal. And then what do you do with those patients? Because they have heart failure and they have some ECG changes. So that is what we are going to be discussing today. Of course, it's a dramatic presentation in the ER, and by and large, even though we may have this talk, I think it would be wise that if you suspect an ACS, you rule out the ACS, because that's easily correctable, and that may be life-threatening most of the times. So again, this is pretty much logic, but of course it's part of the guidelines now. So when you have a patient, you go by the clinical scenario, the chest pain being the most common presentation. Do you decide whether it's an ischemic or a non-ischemic chest pain, whether it's typical or atypical? You don't stop at that. You have to get an ECG. You get a cardiac troponin or cardiac enzymes. And if it's all three are pointing towards, if it's not an ST elevation and if it's a T-wave inversion or a non-ischemic, non-ST elevation ECG with typical history and a troponin, patient is wheeled directly to the cath lab. But if it is not, and if there is a doubt, that's when you have to get involved and get your imaging person to come and have a look, do an echo, and then decide. If the patient's hemodynamics are stable, you have time. If they are not, then again it's a decision that you have to take on your feet. Most of them would eventually undergo an angiogram, and then the further etiologies may be discerned at a later date. So of course, this is a very old cartoon by Frank Netter. It shows a man who's coming out of a bar after dinner in a cold environment, and this is how we used to describe the ischemic pain with all the triggers. And this is ingrained in our minds. Of course, it's the character, all of this has been ingrained, but many times in clinical practice, you may have patients coming with either typical chest pain and not having an ischemic event, or completely atypical or asymptomatic at times and having a blatant ischemic event ongoing. So that's why we don't stop only at the clinical history taking. We look at the ECG, we look at enzymes, we look at an echo in the ER itself. Because apart from MI, there are certain emergencies which need to be treated. It could be an acute pulmonary embolism, it could be an aortic dissection, it could be a non-cardiac event like a tension pneumothorax. So it is important that we take everything into consideration when we are looking at a particular patient. Now, the mimickers of ischemic heart disease or MI, Dr. Pankaj had initially given you an exhaustive list, and this just adds to that list. So it could be anything and everything under the sun. And it could be a complication, long-term complication of the ischemic heart disease like an LV aneurysm. It could be electrolytes. It could be just some channelopathy, or it could be just pericardial diseases which may not really require any aggressive intervention. So it's important that we understand and we interpret given the light of the clinical scenario again, put the ECG in perspective, and then do a thoughtful 2D echocardiogram and then correlate it. So again, this would make you wonder that is this magic that we are talking of. So it's not really magic, it's just pure logic, and we'll see how. So now we'll go directly to the case scenarios. There are about 10, 12 cases. You can stop me whenever you want. So this is a 36-year-old female. She was on COCs and she was a victim of road traffic accident with polytrauma. She was confined to the bed, recovering. Suddenly on day 7 of illness, she has acute onset shortness of breath with a presyncopal episode. There is mild hypotension, tachycardia. ABG is showing some hypoxia. D-dimer is obviously elevated now with so much of going on. We are not sure whether the D-dimer should be interpreted correctly or not. She has reasons to have a lot of things. Get an ECG. Look at the ECG, and if you look at this ECG, I'll use the pointer here so that, yeah. First thing that you notice, there is tachycardia. So there is sinus tachycardia. There is a right bundle branch block, anterior T-wave inversions. And of course, there is something here. You have a deep S1, Q3 and a T3. So I think the diagnosis is pretty much clear. Looks like a pulmonary embolism. The diagnosis may be clear. We still do an echo because we want to rule out whether the patient is having tamponade. And if you look closely, this is the left ventricle and it's the size of the right ventricle. It's the opposite. So the RV is dilated. Now mind you, it's not always that a chronic event will cause the RV to dilate. Give a few hours to a pulmonary embolism and you will have a RV dilatation. It depends upon individual patient to patient. So an echo is important in pulmonary embolism, not only to diagnose, but to rule out other mimickers of pulmonary embolism, because pulmonary embolism is a great mimicker himself. So you have this patient and now you have a submassive to massive pulmonary embolism. You get a CT and the CT also confirms the thing. Interestingly, if you look at the management of pulmonary embolism, if there is hemodynamic collapse, the protocols are in set. You have to thrombolize and again ensure the patency. But if you don't have hemodynamic collapse, which again is a sizable population, especially in the perioperative stage, you are not sure whether the blood pressure is that low or whether the patient is doing okay. So in such situations, your two other things come into play. One is your imaging, the other one is your cardiac enzymes. So if you, apart from a clinical score, if you have a 2D echo which is showing RV dysfunction or a CT which is showing RV dysfunction, and you have borderline elevated troponins, that helps you to say that this is at least an intermediate to high risk of a pulmonary embolism. Definitely keep a watch over the next few hours, thrombolyze if required. Now that's okay if the patient is an indicated case of thrombolysis. Coming back to our patient, she had a recent surgery, so it becomes difficult. She had a polytrauma, so it is almost a contraindication for thrombolysis. So this is a situation where today we can offer them percutaneous options. There are two options. One is we used to do a percutaneous right heart catheterization and thrombolysis locally, or now we have certain aspiration catheters which the radiologists have been using for a few years. Now we have started using them for pulmonary arteries as well. So we can go there and suck out the thrombus. So when you have such a patient, and this is not a very uncommon patient, it is a good idea because you have saved the life of this patient. And again, it's important that we take a thoughtful decision. It's never a single person deciding it, it's a team. This is a second patient. He's a 55-year-old male, diabetic hypertensive, post-CABG, ischemic cardiomyopathy with a CRT-D device. He's doing well on guideline-directed medical therapy. Now he's admitted with an acute febrile illness and AKI with oliguria. The echo on the right-hand side shows that these patients, the EF is going to be as such. So you have recorded a prior echo and the EF is similar, 30-35% or even lower, but that doesn't explain the current scenario. You have an ECG and the ECG looks ghastly, the second one looks even worse. So what do you think is going on? So I think I would look at the ABG in this patient, get the electrolytes of this patient, and as expected, it looks like progressive hyperkalemia. The electrolytes were 9, potassium. So again, going back to our basic training, though it's not necessary that the level of potassium has to match the ECG changes, but most of the times they correlate. So if you have tall peaking T waves, you remember it in such a way that you keep adding potassium and the T waves keep going up. So it's a tall peaking T waves. Then you have progressive QRS and PR widening, eventually a sine wave pattern, and that can result into ventricular tachycardia or fibrillation. Of course, management of hyperkalemia is managed very well by all of you, so I won't dwell into it. But we need to diagnose and we need to be sure. Then again, we have a 42-year-old female. She had a recent supramajor gastric surgery. It was an emotional trauma, subsequent attempted suicide, and she came out of that, and then she had a stormy course, second time reoperated, post-operatively on inotropes, and pre-procedure, somebody had done an echo, it was normal, there was just a mild pericardial effusion. Post-procedure, she is still on a ventilator, and the anesthetists and the hepatobiliary people call you. They ask you that, look, we are not able to wean off this patient because the inotrope requirement is still high. Can you have a look at the echo? So you obviously are the smarter one, so you'll say, first let me see the ECG. So you look at the ECG and you see that it's not a very deceivingly normal ECG. There are some T-wave inversions, there is some borderline QT elongation, and there are some very critical PVCs. Now, when we talk of these PVCs, when they are early, they are coming on the T-wave. As I talked earlier, when you have a PVC coming on the T-wave, that's the critical zone. You have to be watchful because these patients can develop a R-on-T phenomena and a VT. So, given this entire scenario and this ECG, again, it's not a typical ischemic ECG. So if you now, I want you to concentrate here. Of course, these are all real-time examples, so you will find that the image quality is not going to be good, but then we have to work with what we have. So this is a bedside echo machine, which is there in most of the ICUs. If you look at the black zone, that black zone here is what is not seen because there is apical ballooning. That's the 4-chamber view, and that's where the apex, LV apex is supposed to be there. It's not contracting and it's dilated. And if you look at the basal segments here, which is also seen here, they are contracting well. So it's called as the broken heart syndrome or the Takotsubo cardiomyopathy. It is a stress cardiomyopathy. It was described by the Japanese. It is an instrument which is used to fish out octopus. So it has a belly, and it is like a narrow neck and a large belly container. So this stress cardiomyopathy typically comes in an ICU setting, and it typically mimics an MI. In fact, most of the patients would have undergone an angiogram, and initially we used to insist that if you have to diagnose somebody as a stress cardiomyopathy, they should have a normal angiogram. Now with the complexities of other specialties and we getting more and more referrals, it is more common than uncommon. So it is important to look for these subtle signs, subtle ECG changes, and very predominant echo findings to be sure. Now this particular patient, because of the gender, the emotional stress, and the other ionotropic requirements, it was very easy for us, and it was virtually impossible for us to take this patient up for an angiogram. But we were sure about one thing: it seemed to be like a typical Takotsubo cardiomyopathy. So the management changes that we advise is that we have to come down on the inotropes, treat the heart failure, come down on the inotropes, and gradually, depending upon the overall prognosis of this patient, most of the patients would come out, would have significant recovery of LV function, to some of them having absolute normal LV function, to some of them having moderate LV dysfunction. So, but it's important to know that such an entity exists, because in the intensive care, when you're giving an opinion, a lot of things are going on in your head and you're not sure. So it's always a good idea to use your phone, record it, go through it again, take an informed decision as to whether or not this is an ischemic event which you need to shift the patient now to the cath lab, or it's something which is more systemic and which can be managed better by an intensive care person than you. Now there was some data on Takotsubo cardiomyopathy, and there was a diagnostic score which was there, which is pretty self-explanatory and pretty logical. Since it's a stress cardiomyopathy, there has to be a stressor, and emotional stresses were thought to be much more important than physical stresses. Female gender had a higher prevalence, and typically these patients have ST elevations, or transient ST elevations were found in nearly 50% of these patients, and dynamic STT changes. So a lot of things are pretty systemic in this, and it's just been formulated into a score to give you an idea that it's something which the entire world is now looking at as a diagnosis. Again, a lot of theories are there as to its genesis, but what we have understood is there is microvascular spasm because of sympathetic overactivity, which results in a dynamic LVOT obstruction. So you need to treat all these aspects, and that is the basis of management, that you give good conscious fluid hydration based on the pulmonary artery wedge pressures if possible, plus come down on the inotropes. And the background guideline directed medical therapy for all heart failure continues in these patients. This is another 32-year-old male. Again, he comes to you with exertional dyspnea of 3 months with an episode of syncope. He has a ejection systolic murmur, and it's if you do a dynamic auscultation, it's positive for that. Now, if you look at this ECG, there is definitely LVH, and there is a T-wave inversion with a biphasic kind of a T-wave in V3, V4. And so it's basically LVH with strain. And based on the clinical scenario, I think most of us would guess that this is a patient of a hypertrophic cardiomyopathy. The 2D echo here shows very characteristic things. If you look, this is the plaques view of the 2D echo, and this is the interventricular septum, and it's really thick. And it's so thick that there is something called as a systolic anterior motion of the anterior mitral leaflet. So it causes a dynamic LVOT obstruction. It causes an MR. And the gradient across the outflow of the LV is close to 130. So this is definitely obstructive HCM. And this patient, of course, underwent the routine evaluation for sudden cardiac death, as well as was advised a surgery. So he underwent a ICD placement because he had a syncope, HCM, and there was MRI showing significant scar and fibrosis. He was placed on guideline-directed medical therapy and underwent a surgical myomectomy and is doing well now. Now this is another gentleman, he is 67-year-old male with a family history of sudden cardiac death. There was a history of HCM in him about a decade ago. He was advised as ICD, underwent a dual chamber ICD. Subsequently, now you see the age, we had a young patient who had come with normal LV function, whereas as age advances, HCM progresses and becomes dilated. So this patient grew with the HCM and eventually later on in his life landed up having severe LV dysfunction. And of course his coronaries were normal, but he came with the complications of HCM that we dread. He came with recurrent ICD shocks. And this all started with a surgical event, and the surgical event was absolutely fine, but after that he went into something called as a VT storm. And we couldn't really make out what was going on. And if you look at the ECG here, there are two ECGs. The one on the right is bizarre. You can't see a P wave and you can see it's in tachycardia. Patient was having a VT. And on the left is what after we converted him back to sinus. Of course, he was in a storm, so it was very difficult for us to manage this patient. And if you can just look at the ECG, the 2D echo. So echo-wise, LV function is about 30%, and there is dilatation of the apex, so it's apical pseudoaneurysm, and that was the origin of the VT. Of course, we did manage to ablate that zone. We advised a VT ablation. It took 2 sessions. After that, the patient was advised a transplant because he had incessant VT runs. He underwent the transplant, unfortunately didn't survive, but then this kind of a subset is likely to have a very poor prognosis. So it is important to prognosticate the patient, and this prognostication requires you basic investigations like an ECG and a good 2D echo. Just a few more cases. So 66-year-old chronic smoker and an alcoholic. Again, significant coronary artery disease, underwent a CABG, advised an ICD for poor LV function and non-viable myocardium. He is doing very well, unlike the previous patient, and he is coming walking to you. But he comes suddenly with, after an alcohol binge, he has acute onset breathlessness and recurrent ICD shocks. Now this was one ECG which recorded 2 events. So if you look here, this is a VT ongoing, and if you look at the inferior leads, it's more of a negative, so it's coming from the apex. And immediately the spontaneous conversion of the VT resulted in a normal narrow QRS pattern, which was of course showing a poor progression and old MI changes. Now if you look at the echo of this patient, it's ghastly because this is the LV apex and it's dilated. It's an LV aneurysm, and this guy is doing really well. So NYHA, one patient with an LV aneurysm, and he's coming because of an alcohol trigger, his drugs were not working. So we had to really ask him to cut down on the alcohol, stopped his alcohol somehow, and saw that he didn't require any other intervention. And he's been living for the last 5 years with this LV aneurysm. Again, a few benign ones, a 28-year-old male coming to you with fever, polyarthralgia, and atypical non-ischemic pain. There is mild pericardial effusion on the echo, and if you look at the ECG, there is a PR depression with diffuse STT changes. It's very commonly seen in pericarditis. So it's a patient of acute pericarditis and he has to be managed like that. Versus a 24-year-old female who comes with a long-standing weight loss and fever history and comes to you with a pericardial knock. We are looking at something called as a constrictive pericarditis. Again, these patients will have very chaotic ECGs, atrial flutter, atrial arrhythmias, atrial fibrillation, along with diffuse STT changes. And there are certain characteristic ECG echo findings which an expert echocardiographer can tell you straight away that this is going into pericardial constriction or not. Whereas certain emergency situations, like this particular biker coming to you, and he shows that there was a blunt trauma to the chest with hypotension and muffled heart sounds. Now, just an echo makes the diagnosis very clear. This patient is in tamponade and requires an urgent pericardiocentesis. One complication which we all dread in the cath lab is, well, this patient was undergoing a transjugular procedure and suddenly there was hypotension and there was desaturation. So this is what we dread as, what we suspect as air embolism. Now look at those very subtle ECG charts. The ECG is not really helpful here, but there are subtle ECG ST inferior wall elevations which we see, because many times the RCA is the one that receives the air because of its orientation, and patient has a transient MI like a ECG. Now, so if you can look very closely here, this white zone here is actually the air in the pulmonary, and that much was the air because it was a 10 French catheter which was placed and it just sucked in air, and then we just put in a catheter there and aspirated, and on the left if you can see the ECG seems to have settled a bit. So it's important to be watchful as to what is happening, because it's not always that the echo or the ECG is going to help you, but you need to be sure what you are doing. Just 2 more cases and we are done. So one is of course a history of syncope in a young male, and this we have actually already discussed. It is a case of a Brugada. So you have a seemingly normal patient with a syncope. Echo will be normal, but ECG will show typical Brugada pattern ECGs. Again, this is an interesting case because this we find more often. You have a very young boy coming with recurrent palpitations, and clinical evaluation is normal, troponin is normal. Now since he is 23, we are not really talking of an angio, but if this were a 40-year-old with this ECG on the left, on the right, I think most of us would have landed up thinking that this patient has had an inferior wall MI. If you look, there are Q waves in the inferior leads. But if you look at the echo of this patient, echo is absolutely normal. So if you look closely now, I will try and just zoom it up for you. So if you look at the PR is shortish, and the QRS, it's like a left bundle with a slurring of the QRS. So this patient is possibly having a WPW syndrome. So it's an accessory pathway, or a WPW manifest pre-excitation and not an MI. But it's very common that if you have a slightly elder patient, they would have undergone an angio with this kind of an ECG. So it's important to correlate all the 3 things together and then decide. Of course, last is, many times we get a call from the surgical ICU that this patient is crashing, please come and have a look. And they show you this monitor, they say this VT is not going, we have shocked them 5 times. Just take a moment and just see not only the ECG, but also the saturation. So it's saturation and ECG have to correlate. Now you look at this, there is a tachycardia, but the saturation probe is also showing chaotic activity. This is a true VT on the right side, whereas this is because of mechanical movement of the cables. It's a noise. So you need to be sure and don't go by what they are going to tell you. Take your decision on your own. And this is very common in emergency situations because everybody is hassled. So of course, to conclude, ISD mimickers are a major cause in ER and the ICU, and a methodical clinical evaluation, ECG and echo correlation is mandatory to give you a proper diagnosis. And of course, there is nothing magical about it. Thank you for your attention.
Thank you, sir, for your valuable insight. I now hand over further proceedings to Dr. Sohal Parate.
Now I invite Dr. Ashish Nabar sir for his lecture on interpreting pacemaker ECGs. Sir is consultant cardiologist and electrophysiologist at Jupiter Hospital, Thane, Lilavati Hospital, Mumbai. He is visiting consultant at Cardiology KEM Hospital. Sir is the first in the country to be awarded PhD in cardiac electrophysiology. He has vast experience in the field of cardiology with many publications, more than 50 publications in international and national journals, and extensively he has given lectures in international and national forums. Dr. Ashish Nabar sir.
Sorry for this delay. I have taken the permission of Dr. Harkut to slightly tweak my topic, and I'm going to talk on how ECG can be useful in managing CRT, cardiac resynchronization therapy, or the biventricular pacemaker that you all must have heard a bit from Dr. Narasimhan's talk. But just that how the simple ECG can be used to Okay. So, can ECG guide cardiac resynchronization therapy? Now, all of you know that by cardiac resynchronization therapy for last 25 years, what we meant was a biventricular pacemaker, which is CRT-P, and sometimes you have a device which has the pacemaker as well as ICD, which we call as CRT-D. Once again, Dr. Harkut is a great friend and I love coming, I always accept his invite very easily. And this time we are further lucky to have this on a bigger platform with the IMA and the Cardiology Society of India, the Maharashtra chapter supporting this event. So I'm happy to see all of you here. Now, usually cardiac resynchronization therapy, what it's doing is it is resynchronizing the ventricular contractions. So there is a LV systolic dysfunction, but on top of that there is a dyssynchrony in the way in which the left ventricle works. For example, the cartoon on the left shows you that all that orange is equally distributed in the left ventricle. So the activity of the ventricle is synchronous. The septal wall and the lateral wall, there is not much difference in timing. Whereas if you see the cartoon on the right, you can see that patient has a left bundle branch block. So the red is early and the blue is late. So the septal wall is activated early and the lateral wall is activated late. So you have, for example, if you do this kind of a strain imaging, you can see that the left graph, all the lines are synchronous, whereas in the left you can see that first the septum contracts, that time the left wall is relaxing, and when the lateral wall contracts, the septum is relaxing, and that you can synchronize by this CRT, wherein you put a lead in the coronary sinus and so with the right ventricle and the coronary sinus lead, you can time the activity such that you can synchronize the left ventricle contractility. So that is what biventricular pacing is about. And the role of that is established in patients who have LV systolic dysfunction, who are on optimal medical therapy yet symptomatic. They have an improvement in symptoms, less hospitalizations, there is a mortality benefit, and in fact the LV also works better by reduced volumes and better ejection fraction. But the irony is that only 70% of the best selected cases will respond. So 30% non-responder rate for a costly treatment in the patient whom you give hope of improving heart failure when they don't respond is something that becomes little difficult to and challenging to explain in the clinic. So therefore we should look at the selection of the patients a little better, and best is to read the ECG in a much detailed or a critical way. So when you have a patient with LV systolic dysfunction who has clinical heart failure and already on optimal medical therapy, whether you can do a CRT, you look at the QRS duration, as most of the trials have looked at. You look whether the QRS is fragmented, or study the morphology carefully. In the morphology, you also study the amplitude, because low amplitude suggests, low voltage suggests diseased ventricle, and the pattern of widening of QRS, what kind of a bundle branch block it is, because left bundle branch block probably is the most ideal candidate. When should you look at the ECG? Best is that after you have diuresed an acute LVF patient, sometimes the voltages increase. The left ECG is when he came in with pulmonary edema or acute decompensated heart failure, and when you diurese adequately, the systolic voltages would look better. So sometimes it's best to assess the ECG after adequate diuresis. Now to decide the CRT, what matters? Is it the QRS duration or is it the QRS morphology that matters more? Most data from most trials is based on what is the QRS width. That has been the selection criteria in most of the trials, and the greatest benefit has been seen when the QRS is more than 150 milliseconds wide, so close to 4 small squares. And is it different whether you select a patient with left bundle branch block morphology, right bundle branch block morphology, or an IVCD kind of a wide QRS? So QRS needs to be wide, but what morphology will give the best results to a CRT treatment? So QRS width is obviously detrimental. We know from previous studies that wider the QRS, the survival of the heart failure patient is lesser. If you look carefully at the graph, if the QRS is 90 to 120, the survival is better than when the QRS is 220 milliseconds. So one fact to take home is wide QRS in a patient with LV systolic dysfunction related heart failure. Wider the QRS, worse is the prognosis in terms of survival. And therefore, all the trials of CRT, although they included patients who have QRS width more than 120 to 130 milliseconds, as you can see in all these trials that were done, and these are more than 20 years back that the studies were done, what actually was noted is that people who have QRS width more than 150 were the ones that who did better. So therefore, and the other aspect that was in the trials is most patients who had LBBB were included. So the gray zones which represent maximum number of patients in each trial were all the ones that who had LBBB. So what is studied most and what has given the most benefit of CRT is patients who have a QRS wider than 150 milliseconds of the LBBB type. So this is probably your most ideal patient to do a CRT. Why? Because there is a LBBB kind of a wide QRS, means the dyssynchrony is more in the left ventricle, and obviously a CRT device synchronizes the left ventricle, and therefore this is going to be good. So what will you synchronize? You synchronize the intra and the interventricular dyssynchrony. There is one more dyssynchrony which you must know, that is AV dyssynchrony, atrioventricular dyssynchrony. So why longer the PR interval, more the atrioventricular dyssynchrony. So the patients who have a LBBB pattern and a prolonged PR are the best ones to consider for the CRT treatment. Let's sidestep a bit. Is narrow QRS a contraindication to do a CRT? Now, I think yes. I think Dr. Shantanu has left, but I could have told that even in his presence that narrow QRS, your echo does not really help you to select patients who are good for CRT. There were two trials that were done. They were either did not show improvement even if there were dyssynchrony parameters on echo in patients who have narrow QRS, or those trials have to be discontinued because of futility. So when you have a narrow QRS, it is really not worth dissecting that group further by doing an echo. At least the trials have not shown that. If you have a narrow QRS and a dyssynchrony on the echo, it is unlikely still that these patients will benefit from CRT. So we do go by the width of the QRS and not by the dyssynchrony that is there on the echo. So most of the trials that are outlined here, except one, showed that the narrow QRS patients, that is QRS less than 120 milliseconds, are not candidates for CRT. Whether you do a cardiac contractility modulation for them is still open to question, but they are not candidates for CRT. There is no convincing data, even if there is a echocardiographic dyssynchrony in these patients. LBBB clearly outscores LBB patients do better with the CRT. That is a well established fact. The CRT-D and CRT-P are always helpful when you have a LBBB, and they are probably not associated, or they probably even have an unfavorable outcome if you try to do a CRT in a patient with RBBB. But we will dissect this group of patients further. So why does the LBBB do better? I think I already started in my first slide. This is an electroanatomical map. Red means early activation, blue means late activation. So right ventricle, left ventricle. In a LBBB, the right ventricle is obviously activated early. The left ventricle is activated late. The lateral wall is activated last. So therefore what CRT does is there is a pacing lead here. On the RV septal side, there is a pacing lead here in the coronary sinus, and by adjusting the timings in which these two leads pace, obviously you can synchronize the left ventricle and you can have a better outcome. But are all LBBBs same? not. So if you look at the ECG on the top, you can see if you look at V1, V2, V6 that the QRS has a very sharp downstroke. These are not the patients who do good with CRT, but actually that doesn't mean that I'm asking you to exclude patients from CRT because they have this feature, but the patients who have a slight slurring on the downslope, I don't know whether you can see it very easily here, for example. So patients who have this kind of a slur on the downslope, which is considered as more typical LBBB, they are more likely to be CRT responders. So understand the detailing that you must do while reading a ECG. Once again, let me warn you, I'm not asking you to exclude this patient, but this patient is likely to do better with the CRT because he has so-called true LBBB. Once again, we said that there is a 30% non-responder rate when you do even in a classic indication. Why is that? Because all LBBB or all wide QRS from LBBB is not the same, because you don't know where the delay is, and the cardiac resynchronization therapy is synchronizing the ventricular activation. So LBBB may mean there is actually a bundle branch block, or there may be delay in the myocardium because of scarring, hypertrophy or dilatation. So all that also decides whether your best selected candidate with the LBBB will benefit from a CRT. The most important thing is whether there is a scar in the myocardium. For example, this patient with dilated cardiomyopathy on an MRI scan. So one thing I have again introduced is that MRI is helpful to probably decide if CRT will benefit, not that it is a part of workup in every patient, but for example here is a non-ischemic cardiomyopathy, or what you commonly refer as dilated cardiomyopathy. So these patients with LBBB are more likely to respond as compared to a patient, the one that Dr. Jhala showed, hypertrophic cardiomyopathy, who gets dilated, who has a lot of scarring in the ventricle. This patient is likely to be less responsive to CRT therapy. So that's why all LBBBs would not respond to the same extent. So what do we know today? Patients who have a QRS more than 150 millisecond of the LBBB type are the best candidates to do a CRT. The second best candidates are probably LBBB, which is above 130 milliseconds but less than 150 milliseconds, and the non-LBBB kind of IVCD who is above 150 milliseconds. So these are probably the ones whom you should probably not refuse to do a CRT if his heart failure symptom despite optimal medical therapy is significant. One more hint while you are dissecting the ECG carefully and making a CRT indication, what you can see here is that the QRS is fractionated. So these kind of fractionated QRS patients who have a wide QRS, if you think they are candidate for CRT, then your device better be a CRT-D, because fractionated QRS has correlated best with the risk of ventricular arrhythmias in future. So therefore, if your QRS is fractionated, then instead of playing a minimalistic role of doing CRT-P, you should do a CRT-D, which is a combination device of a resynchronization therapy as well as an ICD. There the primary prevention indication for preventing sudden cardiac death would probably be more correct. Now there's one more concept that I think Dr. Narasimhan introduced, was sometimes you may have to, your CRT may have to extend further than only a coronary sinus lead. You may have to do what is a conduction system pacing. So conduction system pacing is where your lead is driven into the septum to capture the left bundle. So by capturing the left bundle as well as doing coronary sinus pacing, this is the next level of CRT that you can do what is called as a physiologic pacing to give a narrow QRS as good as this. So if you do, the narrower the QRS, the better probably the prognosis and the survival and the improvement in the heart failure. So therefore, this is the ultimate that you can do in physiologic pacing. The second question, narrow QRS we said does not benefit. Does RBBB of this kind benefit? What do you have here? An RBBB of the QRBB type, means this patient has an anterior wall infarct related to a proximal LAD occlusion at the RBBB therefrom. Will this patient benefit from CRT just because he has a wide QRS? The bigger question is, all these patients have RBBB, right? If you look at V1, but there is a certain difference in them and therefore some RBBB might benefit. Which are the patients with RBBB which might benefit from a CRT? You must understand that all RBBBs are not same. Once again showing you an activation map of the two ventricles. The same logic, the red is early, the blue is late. So this RBBB, obviously the left ventricle is activated early, the right ventricle is activated late. Now all this left ventricle is activated almost simultaneously. The dark blue doesn't exist here. Whereas in this patient, again RBBB, right ventricle was obviously going to be activated late, but you have a similarly late activated area like this in the left ventricular lateral wall. Which are these patients? Can you identify them on the ECG? Yes. So if you have a RBBB with a left axis, as in this case, then we call it a masked RBBB. There is a left anterior hemiblock along with RBB. So patients who have RBBB with LAHB, these patients have an additional delay in the left ventricular activation, and therefore they are likely to be responders to your CRT therapy. So all RBBs are therefore not the same. In a right patient who has a higher NYHA class, who has received all the optimal medical therapy, is getting admitted with heart failure repeatedly, if this is the patient, then I would go ahead and do the CRT in this patient, but possibly not in these patients, because this is likely to worsen by getting a CRT. So therefore that is the point I wanted to drive home. Any kind of IVCD with wide QRS, where you cannot type them into either RBBB or LBBB type, generally the results are pretty subtle, and therefore you have to better individualize any IVCD whether you should get a CRT. Probably more than 150 milliseconds I would consider, but maybe 130 milliseconds not. So there you have to individualize a bit, that if you really have a wide QRS more than 150 milliseconds and IVCD kind of a morphology in a advanced heart failure, you might consider doing a CRT. One more dampener to treating CRT, giving CRT in a patient with heart failure who has all the appropriate criteria, is the atrial fibrillation. And many times you can't escape atrial fibrillation in a heart failure patient. The worser the NYHA class of heart failure, more the chance of him having a atrial fibrillation. Why atrial fibrillation patients might not do well if you give a CRT is something because of this. For a CRT to be beneficial, you must continuously biventricle pace. So in patients with sinus rhythm, what we do is we program the sensed AV interval, as it is called. So after sensing the P wave, your both ventricular spikes are given at an interval shorter than the natural PR interval, so that you continuously pace the ventricles. Only when you pace the ventricles more than 97% of the time, you will get the benefit of CRT. When you get atrial fibrillation like this, even though he has a LBBB, this patient might not benefit, because with this fast ventricular rate, you will not have a high rate of biventricular pacing, which is required to give a responder status. So therefore, what we do in these patients with heart failure with atrial fibrillation who need a CRT is you ablate the AV node. Just giving AV node blocking drugs does not slow the ventricular rate all the time to give a 97% biventricular pacing. So you ablate the AV node, so effectively you make him pacemaker dependent, but in return you get a continuous biventricular pacing, and if that indication was correct, then he is likely to be responder, because now he has continuous biventricular pacing. A few ECGs which might be useful when you see these CRT patients in the follow-up, because they are more and more being done, and therefore it is good to know a bit. Most important is that you will get a V1 will have some R wave when there is a LV capture. Yeah, when you capture the LV, you will obviously get a R wave in V1. That's like a right bundle branch block, right? You are pre-exciting the LV by pacing the LV. So you'll get some hint of R in V1. Your axis could be, because you're pacing the LV from the left side, your axis could be either rightward or northwest, depending on where your lead is pacing the LV. So these are some of the pointers, and I show you some of the ECGs. For example, here the QRS is, well, not too narrow, but you have a right bundle branch block pattern in V1 and a right axis. So therefore the left ventricle is being paced, And if you see at that pacing spike, it is a little thick. So there are two spikes, one from the RV side, one from the LV side. So that's how you can interpret a patient with CRTP. Here you can see that although the LV is paced, there is no RBBB in V1, but the axis is rightward. This cannot happen with a patient who has a RV pacing. The axis has to be leftward or something like that. So therefore you know that this patient has a CRTP. Another ECG where the V1 clearly shows a right bundle pattern. So although the axis is leftward, like in a patient who has a RV apical pacing, but RV apical pacing never gives a right bundle branch block pattern as in V1. So this patient has a CRTP. So having done a CRT in a patient who has all the ideal criteria, that is sinus rhythm, left bundle QRS more than 150 millisecond wide, the responders are likely who have this kind of a narrow ECG. So you have to narrow the QRS as much as possible to give a responder status. How do you do that in a follow-up? You can program your AV interval such that you have a biventricular pacing, and you can program your LV and RV timings. The LV has to pace earlier than the RV. So by doing these manipulations, I don't wish to take you into too much of details into this, but we can program the device after the implantation also to obtain as narrow QRS as possible, and that's the most simplest way in the clinic to achieve responder status. I think I'll stop here, and I thank you for your attending. Thank you very much.
Thank you, sir, for such a wonderful lecture. We can take questions now only, if anyone has question. Thank you, sir. Now I invite Dr. Rajkumar Ghumre, sir, for supraventricular tachycardia ECG approach. Sir has done his cardiology from Escott Heart Institute, New Delhi, fellowship in electrophysiology from Medanta Medicity, Gurgaon. Currently practicing in Orion Critical Care Hospital, Sambhajinagar since last 9 years. Dr. Rajkumar Ghumre, sir.
Good afternoon, everyone. At the outset, I would like to thank IMA Nagpur branch, CSI Maharashtra branch, Dr. Pankaj sir and the entire Swasthyam team for having me here for this ECG symposium. On a Sunday, it's very heartening to see so many physicians coming here to learn ECGs and various conduction system disorders, their management. We have had very good talks from the stalwarts like Narsimhan sir, Nabar sir and many of my colleagues. My talk is a little more basic. We are going to discuss approach towards ECG diagnosis and management of supraventricular tachycardias. Now all of us who are practicing physicians, intensivists, it's not uncommon for us to see young patients presenting to ERs with complaints of palpitations. Usually in the age range of 20 to 40s, they have structurally normal heart. Most of the time they are hemodynamically stable. Clinical examination, apart from the tachycardia, we don't have anything. Elderlies presenting with SVTs may have borderline blood pressures, but usually younger patients have maintained blood pressures. If we get an echo, it is usually normal in these cases. So this kind of ECG is not uncommon for us to see in the ERs. We see a good narrow QRS complex regular tachycardias, and we commonly tend to label it as PSVTs, paroxysmal supraventricular tachycardias. So how do we approach such patient? How can we differentiate such ECGs? Can we come to a certain diagnosis? How to manage these patients? We are going to deal it in brief. So supraventricular tachycardia, actually it is a very broad or a generic term. It includes all tachycardias wherein the arrhythmia circuit is either partially or completely above the ventricles, that is limited to the atria. So This is the long list of supraventricular tachycardias per se, but we use the term supraventricular tachycardias mainly for those AV nodal reentry tachycardia, atrioventricular reentrant tachycardia and atrial tachycardia. These three tend to present more in paroxysmals. So they usually are more likely to present as PSVTs. So this is the incidence of various supraventricular tachycardias. As the aging population is increasing in India, we are going to see that atrial fibrillation will occupy more of this pie chart. So aging population is more likely to present with atrial fibrillations and flutters. So when we are faced with such an ECG, the diagnostic approach, I have tried to put it in 4 steps. First of all, we'll look for the regularity of the QRS complexes. If it is regular or irregular, depending on that, we'll go in the algorithm. Second is look for presence of P waves. Are you able to see some P waves? If the P waves are present, then again we have certain steps. And third, we have to look for RP interval. I'll come to that when we go ahead. And lastly, if we are not able to differentiate it from these 3 steps, we can do certain maneuvers like a vagal maneuver, or you can even use a AV nodal blocking drug like an adenosine to give us the diagnosis. So firstly, we are, whenever we see a narrow QRS complex tachycardia and we come to a conclusion, we use the usual paper and pen method to see whether it is regular or irregular, and we find that it is not regular. It is fast and not regular. So the 3 common likely differential diagnoses come to be either atrial fibrillation, flutter, or multifocal atrial tachycardia. We'll go through each of them. So not a very difficult diagnosis when we are faced with such an ECG. Irregular QRS complexes narrow. We can even appreciate in lead 2, we can even appreciate the F waves or the fibrillary waves. So a straightforward case of atrial fibrillation. But this may not be case always. When the patient's ventricular rates are fast, if with fast ventricular rates, if the rate is in the range of 190 to 200, sometimes it may be difficult to ascertain whether it is regular or irregular. We get a call many times from the ICUs that patient is having SVT, we have tried adenosine, it's not helping. It is because the ventricular rates are fast, the resident doctors are not able to make out the irregularity. So what we can do, sometimes to make out the irregularity, we can increase the ECG paper speed. From 25, we can make it 50, and we may be able to make out the irregularity. Another is try a vagal maneuver or a drug to slow it down, and that may also bring out the irregularity and help us in achieving the diagnosis. This one, is it clear? So again, narrow QRS tachycardia, irregular with the classical sawtooth appearance seen in the lead 2. Not a difficult diagnosis, atrial flutter with variable AV conduction. And the third, narrow tachycardia presenting with irregular rhythm is this one. This is usually seen in patients admitted in ICUs, usually patients with COPDs, pneumonia, sometimes even in valvular and heart disease and cardiomyopathies, but more commonly seen in patients of lung diseases. So as you can see, I have put the pointers also for guidance. So 3 or more different morphologies of the P waves are seen with varying PR intervals. This is, can anyone tell me the diagnosis? Yes, it's a multifocal atrial tachycardia. So the treatment of these tachycardia usually lies in reducing the drugs which you are giving. Many times these patients are on theophylline, beta-2 agonists, very high dosage when they are admitted with exacerbations. So try to tone down the treatment, and many times that may help in treating such patients. So 3 irregular we have seen. I have tried to simplify it. There may be certain rare ones, but I have tried to just simplify the differential diagnosis. So we have had a look at the irregular ones. So let us go ahead with the regular ones. If the tachycardia is regular, second step which we have seen was look for presence of P waves. So if P waves are seen, the next step what we do is look at the ratio of P waves as to QRS complexes. Is it equal, or if the P waves are more than the QRS complexes? So if we have a look at the ratio, and if the P waves are more than QRS complexes, 2 possible diagnoses again. So it has to be either a atrial flutter or a atrial tachycardia. Let's have a look. So this is a regular tachycardia, and again we are able to see the flutter waves, but the conduction here is not variable. We had a atrial flutter with variable conduction, we had irregular tachycardia. Now we have atrial flutter with 2:1 conduction. So this is it's presenting as a regular tachycardia. So this is atrial flutter with 2:1 conduction. Again here in atrial flutter, if the rates are fast, we may not be able to find out flutter waves like this. So again we have to use certain maneuvers to bring out the flutter waves in such cases. This is a case of, see, can you see the 2:1 conduction? There are two waves. The first one P wave is easily seen preceding the QRS complex. The second P wave is seen on the top of T waves. Look at lead V1. Can you appreciate the second P wave? So it's a atrial tachycardia with 2:1 conduction. So if the ratio of P waves is more than QRS complex in a regular tachycardia, the two common possibilities are either a flutter or a atrial tachycardia. There are certain other possibilities, I will not go into those. So we'll just keep it limited to simple ones and the commoner ones. So if the ratio of P waves is not more than QRS complex, that means there is 1:1. So the ratio is 1. So number of P waves is equal. Then we look for something called as RP interval. Just like we have PR interval, we have RP interval. So if the RP interval is more than the PR interval, we have some differential diagnosis. There is a list of 4 or 5 tachycardias, but for practical purposes, long RP tachycardia for us will be limited to either atrial tachycardia or the common one, sinus tachycardia. The two uncommon ones, that atypical AVN RT or PJRT, these are rare. PJRT is a pathway related tachycardia, and atypical AVN RT. These are rare ones, even SNRT. These 2-3 tachycardias are very rare. So practical purposes, long RP tachycardias has to be either a atrial tachycardia or a sinus tachycardia. And depending on the clinical presentation, we may be very easily likely to differentiate between the two. So here have a look at the RP interval from beginning of R wave to the beginning of P wave, just like PR is from beginning of P to beginning of QRS complex. So RP interval helps us in making out whether it is a we can differentiate the various SVTs with the help of RP interval. So now this is a regular tachycardia, number of P wave. Can you appreciate the P wave? In inferior leads, I have kept a pointer there. So we have P waves in the ratio of P waves and QRS complex is 1, and RP interval, can you appreciate whether it is short or long? The RP interval appears long. The PR is short. So RP interval is long. So it has to be either atrial tachycardia or sinus tachycardia. So if it was a sinus tachycardia, we would not expect the morphology of P wave to be like the one which is shown here. So it is inverted in 2-3 AVF. So the origin more likely to be from somewhere in the low right atrium. So on the basis of the morphology, we can also try to pinpoint the origin of the atrial tachycardia. Second, if we have shorter PR interval, so we have seen longer RP interval, that is either atrial tachycardia or sinus tachycardia. Now let us go to the shorter RP interval. If the RP interval is shorter than PR, then we can further differentiate that into whether it is very short, whether it is less than 90 milliseconds, that means 2.5 small squares, or if it is more than 90 milliseconds. So if it is very short, if the RP interval is very short, less than 90 milliseconds, the diagnosis is very likely to be AV nodal reentry tachycardia. That is the most common SVT. More than 50% of supraventricular tachycardias are because of AVNRT. And if the RP interval is longer, again the possibilities are pathway related AVRT, that is atrioventricular reentrant tachycardia, that is related to accessory pathways, or a atrial tachycardia. Atrial tachycardia can present in various forms, long RP, short RP, even sometimes very short RP can also be seen in atrial tachycardia, but I have just tried to simplify on the basis of the common occurrence. So we have this RP interval is short. RP interval, I have shown you this is just P wave is peeping out of the QRS complex. It's also called as pseudo R prime or pseudo R dash. So this is classically seen in typical avian RT. That is, the RP interval shorter than 90 milliseconds. So here it is hardly less than even 40 milliseconds. It's just peeping out of the QRS complex, right? So this is a typical avian RT. If the RP interval is short, but it is more than 90 milliseconds, we have two possibilities, either a pathway related AVRT or an atrial tachycardia. So in this example, we have the RP interval is shorter if we compare with the PR interval, but it is more than 90 milliseconds. This patient is more likely to have a pathway related AVRT. So this brings us to this end of the algorithm, but we have one scenario where the P wave may not be seen at all. So if the P wave is not seen, it is most likely to be avian RT tachycardia, right? So this this broad algorithm tries to give a simple approach how to approach a patient of ECG with narrow complex tachycardia, either regular or irregular. So the patient who had presented to us had a regular tachycardia and the P wave was not seen. So diagnosis at the end of this algorithm comes to be avian RT. Now this is one frequent problem all of us. This patient was a case of septicemia urosepsis. She was again referred for a the call was given to me that patient has SVT, please come and see, adenosine is not helping. Again, Dr. Saurabh made a very good point how to administer adenosine. The adenosine was given through a IV line on the dorsum of the hand. So by the time the adenosine disappeared, it could not reach the heart. Before that, it was totally metabolized. So the administration of adenosine in the correct manner is also important. So this patient was referred just for SVT, but however adenosine could not help. Why? So following the algorithm, narrow QRS complex tachycardia, regular, RP interval is long. So long RP interval, it has to be either atrial tachycardia or the sinus tachycardia. So if we look at the morphology of P wave in lead 2, it appears to be normal. So this is more likely to be sinus tachycardia. Apart from that, always have a look at the history. Patient was in urosepsis, she was febrile. So this was most likely to be sinus tachycardia. So always when we have sinus tachycardia, we should look for the causes. This is long list of causes of sinus tachycardia and try to treat the underlying cause. But sometimes we do have inappropriate sinus tachycardia. So usually seen in younger females who have tachycardia even at rest, and we have ruled out all the possible underlying causes of sinus tachycardia. So those patients we label them as inappropriate sinus tachycardia, and we can treat them with either ivabradine. Nowadays, earlier the class 1 indication was beta blocker, but now ivabradine is also a class 1 recommendation apart from beta blockers. Radio frequency ablation not commonly done for inappropriate sinus tachycardia. I hope at the end of this we all are not confused. So the SVT patients usually present with palpitations. Patients especially who have underlying heart disease, elderly patients, they may have mild hypotension, so they may complain of giddiness, pre-syncope, or rarely they can even present with syncope. Atypical chest pain is very commonly reported by female patients, but with patients who have underlying ischemic heart disease may have precipitation of either angina or LVF when they develop a SVT. So acutely, I think management part is mostly covered by Dr. Saurav in drugs, but acutely, even he mentioned a very important point that even if the patient is hemodynamically unstable, till you get your defibrillation ready, you should try adenosine for SVTs. So I am a little skeptical when I do a DC cardioversion for a SVT, because most of the time if adenosine given correctly, it helps us in termination. So always try adenosine first, and in increasing doses. Try 6 first, and if 6 does not help, try 12 mg. So either vagal manure or adenosine for immediate termination. If it does not help, and if the patient is hemodynamically stable, we can either try IV beta blockers or IV calcium channel blockers. In here, I don't know whether it was mentioned or not, whenever we are doing DC cardioversion for patients with either SVT, atrial fibrillation, flutter, never forget to do a synchronized DC cardioversion, right? Because we may convert a SVT into VF. So if we don't do a synchronized cardioversion. One more practical tip, vagal maneuvers, elderlies try to avoid, especially if there is a carotid bruit, if there is a past history of transient ischemic attack or a stroke, I would not do a carotid sinus massage. It should be done for maximum 5 to 10 seconds. Try to extend the neck a little bit, turn it on the other side, give a firm pressure for 5 to 10 seconds. Try once or twice, leave it. Other simple maneuvers where even uneducated or illiterate patients can do, the Valsalva is not that easy. Give a firm compression on the abdomen, try to tell the patient to push it out. Or another simple technique which I use is give them a syringe, 10 or 20 cc syringe, tell them to blow in and push out the piston. That Valsalva has helped many times instead of a carotid sinus massage. Again, splashing of ice cold water, which is not easily available. I haven't tried yet. But adenosine, apart from achieving termination of the tachycardias in AVNRTs, AVRTs, even ATs, it can also help in trying to get a differential diagnosis sometimes. So in patients with either atrial tachycardias or flutters, it may bring out the flutter waves or the AT waves. In some tachycardias, it may just, like in atrial or sinus tachycardia, it may just slow down a little bit and again gradually resume. But whereas in AVNRTs and AVRTs, we may achieve termination. So apart from treatment, it also helps us in diagnosing. So further management, nowadays for SVTs in experienced centers, the risk of complications is very low. It's a safe procedure with an ability to cure. It's more than 99% success rate for AVNRTs. So the class 1 indication as per all guidelines nowadays is catheter ablation if the patient is willing. In patients who are not willing, look for the baseline ECG. If there is evidence of baseline pre-excitation, you keep them, and if patient is not willing for ablation, they should, then patient should be treated with either flecainide or propofenone, right? And if patient has no baseline pre-excitation, they can be treated with either beta blockers or calcium channel blockers for long-term medical management. But first choice should always be this we have seen. One just point I would like to make, in patients who have asymptomatic pre-excitation, patient has never had any history of palpitations, but he has asymptomatic pre-excitation. I would recommend to do at least some non-invasive evaluation, risk stratification for these patients. A simple stress test also can be done. If there is a complete and sudden disappearance of the pre-excitation, as we can see here, look at the stage 4, there is complete disappearance of the pre-excitation in this patient. So they tend to have low risk pathways. That means the pathway has a longer ERP and it is less likely to conduct at a faster heart rates if patient develops any atrial arrhythmias like atrial fibrillation in future. So at least try to do some risk stratification. This also has some limitations, even stress test. In patients who have some family history of sudden death and if patient has pre-excitation, I would recommend doing an invasive EP study and assess the risk stratification of the pathway per se and then take a call whether to ablate it or not. This I think you will have in your ECG quiz. So this is actually I wanted to hide it but somehow I didn't. So this irregular complexes you can see, broad and irregular complexes. Along with that we can see pre-excitation. The delta wave is appreciated in some of the QRS complexes. This is a AF with pre-excitation. Management, anyone would like to comment on the treatment? Should we use amiodarone? So the best treatment for these patients is doing a synchronized DC cardioversion, right? Because amiodarone can increase the it can block the AV node and it can increase the conduction through the accessory pathway. It is not recommended. The recommended drugs are either ibutylide, procainamide. Difficult to get. Ibutylide is available in India. Procainamide we don't get in Sambhajinagar. So the drugs are difficult to get. So you do a synchronized cardioversion in these patients. So if you take home message, careful analysis of the ECG. It gives a good differential diagnosis. Most of the time we can reach to the final differential diagnosis. In hemodynamically unstable patients, a synchronized cardioversion, but till then definitely do try adenosine. In stable patients, we can try IV AV nodal agents, and long-term therapy depends on mechanism, and above that I would say the choice of the patient. I would recommend EP study and radiofrequency ablation for most of these patients. Thank you.
Thank you, sir, for the wonderful lecture. We can take questions if anyone has.
Thank you.
Thank you, sir. We'll continue with the lecture series. Panel discussion will take at the end. For the next lecture, I invite Dr. Saurabh Deshpande for VPC explained when to treat and when to refer. Sorry,
Good afternoon once again. So this is one of the commonest problems we might see in our day-to-day practice, premature ventricular complexes. And as you all know, there are more and more monitoring devices which are coming up, like Apple Watches, and multiple other devices are there which can tell you, even find out the minutest of ventricular complexes here and there. There is increasing awareness about Holter as well. So many people come to you with Holter reports of some PVCs coming. So the question is very, very relevant, and when to treat or when to refer for further management. These are all the gadgets you might be aware about, the Apple Watch, and so this is something called as Alive Core Cardia, where you put 2 fingers on that particular device and that ECG can be directly given on your Bluetooth enabled device. In this case it is mobile. This is the Indian version of it, the Sanket Life. Similarly it works. And there are some other gadgets which are in the pipeline, and you might have seen your practice as well. What these gadgets are doing is they are trying to find out the asymptomatic arrhythmias, and some of these arrhythmias can cause problems in our day-to-day practice, as there was a very old study, but it was done in a specific population where you don't expect any abnormality. So Air Force personnel, huge sample size, but still they showed 7.8 per 1000 PVCs in those people. ARIC study is a very well done study. It's a very old study, but every year you will see different sub-studies of ARIC trial, and out of this, one of the sub-studies has shown that there is 1.8% incidence of PVCs. MESA is one of the studies which included India and the area around India, and it has also found out in the rhythm arm of it that at least one PVC in 99.5% of elderly. So the problem is huge. So we face it day to day basis in our clinic or our practice. The risk factors have been found out at multiple studies, like the ERIC study or other study which was done some 1,000 patients, and most of the risk factors are similar to our atherosclerotic heart disease or MI related risk factors. There are some electrolyte abnormalities, or in some cases it was found to be higher in cases of certain situations. So we may not be able to use these criteria in our practice per se, specifically for PVCs. Mechanisms are important, as we discussed during the antiarrhythmic therapy as well. It can elucidate the mechanism if you see the ECG properly. I think in the last lecture also we have tried to find out and elucidate mechanism of some SVTs. Some presentations might be different as per the mechanism of the tachycardia. Automaticity generally presents as a parasystole, and most of the times it is due to the catecholaminergic increase. One of the cases which was discussed before with hyperthyroidism and atrial fibrillation, it works similar way. Again, hyperthyroidism with PVC, it will work similar way. So you treat hyperthyroidism, the PVCs will go away. That is how we say it is automaticity related. Now, how to evaluate? This is a very important and relevant question in day-to-day practice. Most important thing in any physician's practice is clinical evaluation. That is the cornerstone of anything and everything that we do see in our day-to-day life. There are two common presentations. Unfortunately for us, most of these patients are asymptomatic. If they are symptomatic, our job is slightly better and we can directly opt for treatment or refer for specific management. Now, the difficult part in saying a patient is asymptomatic or symptomatic is bringing down that history, bringing the history out from the patients. So what are the types of symptoms that you experience? You all are aware about the palpitation and presyncope and dyspnea and fatigue, that are all directly due to the PVCs. But sometimes what happens, they don't directly present with the PVC symptoms. They can present with the complications of PVCs which have happened to those patients, like heart failure. So if there is a heart failure and the PVC, it's very difficult to find out. It's a chicken or egg situation, whether the heart failure came first or the PVC came first. But that is one of the places where we have to look for those PVCs as a triggering factor. Similarly, if a patient presents with syncope and PVCs are there, so we should suspect that that syncope might be related to a VT, which was there sometime and it has caused the VT. One of the symptoms which I think you all might have seen in your practice as well, that patients develop something called as catching sensation while they are taking breath. So they have to take deep breaths in certain situations. Many a times this has been found out because of the long pause which is there after these PVCs. So we should look for these atypical symptoms. So before labeling, the whole point of this particular slide is you have to bring out those symptoms. So before labeling any patient as asymptomatic PVCs, try to bring out all these minute symptoms and then only label the patient as asymptomatic. Again, in an asymptomatic patient with a family history of cardiomyopathy or a channelopathy, we have to be wary and we have to treat those patients differently as compared to other patients. Now, evaluation will depend on, as I told you, whether asymptomatic or symptomatic. If it is an asymptomatic patient, just look for the how the incident, how the finding has come out, whether it has come on the pulse ox used, whether it has come because of any other device. So in these patients, we have to look for atypical signs like the heart failure signs, or as Nabar sir pointed out in many of his cases, decrease in biweek pacing percentage. So as sir told, 97% is the amount of biweek pacing which is required for effective CRT. We call it effective CRT. So if that is not there, it might be due to the PVCs which are there. Look for the restriction of activities. This is very important. The patient was able to do something, say 1 year before, but the patient is not able to do that today. That patient will not tell you. That we have to bring it out that हे तुम्ही करू शकत होता आधी, or used to do these things and now you are not able to do. So those things are important before labeling the patient as asymptomatic. Now, if the PVC is diagnosed on ECG, we need a longer evaluation. Specifically, we have to look for the 12 lead of all those PVCs. It's important for when you are planning an ablation for those patients. The localization is very well, can be done with the help of a 12 lead ECG. Also, as I think in the morning we have discussed a lot about the scarring. So whenever you have those ECG clues, you can actually find out patient might be having those cardiomyopathies like inflammatory cardiomyopathy or arrhythmogenic cardiomyopathy, left or right ventricular. Those subtle clues can be brought out in these asymptomatic patients as well. Now we have all these monitoring devices. You all are aware about Holters. I will not go into the 12 lead localization, but it sometimes can give you the clue as to patient might be having some underlying heart disease. As we discussed about scarring, there are certain diseases which are more localized to some area, like the Brugada or the ARVC. They are more associated with the RVOT abnormality. So PVCs might be coming from there, and it might tell you to do a certain evaluation. Like if you're doing echo which is normal, then you have to do MRI in those patients just to bring out those cardiomyopathies if they are presenting with those PVCs. Again, varying morphology will guide you towards inflammatory cause because it's coming from here and there. So that's a clue that it is changing morphology. Echocardiogram is the most important thing, evaluation that you can do in a patient presenting with a PVC, because you have to find out whether there is a structural heart disease or not, because that helps us in the management on a short term as well as on a longer term. Now, if many times what happens, if you are measuring the ejection fraction either by any method, M-mode method or Simpson method, sometimes you find that the EF is turning out to be more or less normal. Then you look for the dimension increase in those particular patients, whether they are proper for that age, and if they are higher, then again you suspect that is due to PVCs. Cardiac MRI is very helpful. Many a times the reporting has to be done properly. Unfortunately, we don't have good readers for cardiac MRI, but if you have them, that is a boon to have in these particular subset of patients with PVCs. It can bring out subtle abnormalities and help us in the further management. PET is something called nuclear imaging. You might have heard about it, PET or SPECT. That those are the evaluation specifically if we are suspecting an inflammatory cardiomyopathy subset. Then we can go for PET. Even in cardiac MR being normal, we have found out some inflammatory foci only in PET. So PET positive, CMR negative patients are there in this who are presenting with premature ventricular complexes. Now, once you have evaluated, one of the goals of evaluation is prognostication of the patients. Now, there was a study, very old, but very well done. It was published in 1985. But they found that there were no prognostic differences over 6.5 years of follow-up. But then post-MI PVCs have been always shown to increase mortality, whether it was a CAST trial or the American-based trials, and some ablation-based studies which were done later. So these are the things which we have to look for in any patient presenting with PVC. So what you are doing while you are prognosticating, you are trying to find out whether those patients can develop LV systolic dysfunction in future, or they can have ventricular tachycardia in the future, or I have already had it in the form of syncope. These are the two questions you have to ask when you are evaluating prognosis. Now, LV dysfunction, there have been nice studies. So this was a cardiovascular health study. It's a very nice follow-up of 14 years. And they have found out that there was a risk of heart failure due to PVCs. And it was similar to what can happen in a patient with CAD. How to know that? How to find out whether your particular patient can develop LV systolic dysfunction? There are certain pointers in an ECG. Most important thing is frequency is higher mortality. That is, you can say a general statement, which is not true every time. But then how do you define high burden? So there are multiple definitions in multiple studies. Most accepted definition is in a patient with ischemic heart disease more than 10 per hour, or without any ischemic heart disease more than 30 per hour. That is the most accepted definition today. But the caveat to that is, same study which has evaluated that higher burden causes higher mortality, 20% of these patients actually had a burden of 24% or more, but there was no increase in mortality. So we cannot just rely on the burden. Although this is the first thing we look for, that is not the only thing that we look for. So what are the other things? So it has been found to be higher risk in a male patient, found to be higher risk in a patient who has longer duration of the palpitation. Interpolated PVC. So what do you mean by interpolated PVC? That is shown here. This is the normal QRS, this is the normal QRS, and there is a PVC which has come. It has not caused the compensatory pause after that. That is what is called as an interpolated PVC. Why is it more for interpolated PVCs to cause LV systolic dysfunction? It's very clear from the ECG. So here, patient was supposed to have only 2 beats, but patient is having 3 beats in the same time. So the number of beats that the patient's heart is having in the same time is higher in case of interpolated PVC. So higher the beats, higher the chances of that patient developing LV systolic dysfunction. Variable coupling interval is slightly complicated to explain, but then you should be aware about the coupling interval. This is how you calculate from the start of QRS to the start of the PVCs. There is a scoring for that also. I'll be coming to that later. Broad QRSs, which are maybe from epicardium, again are a higher risk for causing LV dysfunction in future. And as is there in our population even for CAD, that I think cardiologist can tell you, late presentations, patients don't suspect that they have something. That is one thing which can cause LV dysfunction in future. So there are mechanisms. I think Dr. Narasimhan sir in the morning alluded to this. There is something called as tachycardia cardiomyopathy. It can be due to high burden PVCs or long-standing interpolated PVCs. Or second reason is dysynchrony, which has been discussed multiple times today. Dysynchrony was as the basis of cardiomyopathy from PVC the concept has come from a very nicely done study. This was an animal study, but it is strikingly showed you if you pace an epicardium, the animal had higher chances of having LV dysfunction as compared to endocardium at near the conduction system area. So broader the PVCs, more the epicardial origin, higher the chances of those patients developing LV systolic dysfunction. This is a very elegant score, and you can actually calculate it on every halter, even 24-hour halter is enough. That is something called as ABC-VT score. It was published in around 2018, and then there was a study later on to find out how it can be used in a routine population as well. So what it tells you to look at the axis, look at the burden, look at the coupling interval, which I showed you before, and look whether the patient has had ventricular tachycardia, whether it's sustained or not ill sustained, doesn't matter. So these are the points that we give. So this is how you calculate. So if you see this particular patient, the axis is inferior. There is a burden of 14% that you knew before. Coupling interval of 485. Again, it is falling less than 500. And there was no NSVT. So if you calculate according to this scheme, the scores comes out to be 3, which is a low risk score. If it is more than 8, it is considered as a high risk score. So this is I don't say that this is the only score which will tell you, but this is something which can guide you further in the management of the patient. Second thing, as we discussed before, we have to find out if the patient is prone to develop VT or not. So most important or most practical thing that we can look at is something called as coupling interval. As was discussed by Dr. Malav in his talks also, if there is something called as R on T phenomena, if the PVC falls in a very critical zone where it can induce a polymorphic VT, that has to be looked for urgently. So those PVCs have to be treated. So shorter, higher chance of R on T, higher chances of VTVF, very clear. Now there is a controversy in labeling something called as short coupled. So what do you mean by short coupled? But most of the studies tell you if the coupling interval is less than 300 to 350. So in that range, we call it a short coupled and has to be treated aggressively as compared to other studies. There is recent MRI based studies in prognostication of VT. So it is broadly told us that higher the scar burden, higher the chances of patient developing VT. Again, it requires further study, but that is something which can help us. Management of these patients, we have to have the symptom rhythm correlation. Low EF at the first evaluation, if we cannot explain it by anything else, we have to obviously do the coronary evaluation and the myocardial morphology, if possible, with cardiac MRI. If the patient has VTVF, where PVC may be a trigger, we have to look for it if you have the ECG or any diagnostic modality which is showing that. Response of BIV pacing is compromised, as I discussed before, or a patient has high risk features, as we discussed before, the developing LV dysfunction or VT. So the most important thing is reassurance in many of the patients. As I showed you before in my first slide, the prevalence is huge. The first line of management in any patient with PVC is reassurance. So if you feel that it is practically whatever you have evaluated, found out that it is not causing much problem, please reassure the patient everything is okay. Second most important thing is lifestyle management. That is cornerstone for any cardiac disease that you feel. So BP, sugar control, weight reduction, anxiety management, smoking cessation, avoid binging of alcohol, because that, as sir has also showed, the alcohol can cause transient AFs and it need not be treated. Similarly, PVCs can get exaggerated. So management involves medical or ablation. Medical, all of you know about beta blockers, CCBs. Flecainide is one drug which has been found to be useful specifically when you feel the origin or the mechanism of the tachycardia is automatic. Sometimes the combination of flecainide with beta blocker or calcium channel blocker helps in these patients. Amiodarone mexiletine I don't like to give in PVCs, but then many times we don't have any option in cases where the patient presents with LV systolic dysfunction. Catheter ablation is a very good treatment for these patients whenever you feel that treatment is required. So conventionally we can do most of the routine ablation in 2D, but then 3D helps us to point out that focus very well, and you can treat it with a higher success rate as compared to 2D in unusual locations for PVC. The basic disease helps us with the management. If the patient is having inflammatory cardiomyopathy, the line of management changes to medical management, and if a patient becomes inactive and still having PVCs or VTs, then you have to go for ablation or ICD or as the need be. Channelopathy is difficult to diagnose, but whenever you diagnose, if you have a high risk feature in a channelopathy, patient might require an ICD. So this is the gist of management, what you can think about in a patient presenting with PVC. Whenever you have the patient is having LV systolic dysfunction or low LVEF, then look for the go for GDMT. Obviously, that is important with all the lifestyle management that we discussed. Look for the burden. Even with less than 5% burden, if the patient is symptomatic, we have to treat either with the antiarrhythmic agents or with the catheter ablation. With no symptoms, with a low burden, we need not do anything. We just reassure and find out the other reason for LV systolic dysfunction. More than 10% with LV systolic dysfunction, this is not based on any guideline, this is based on the expert review, but they suggest considering treatment, specifically earlier ablation than antiarrhythmic medication. The things become more difficult when a patient is having normal LVEF, because many times patient is not symptomatic and not very much willing for treatment. Again, the burden, most of the times if the burden is low, less than 5%, don't do anything. More than 5%, if with symptoms, we can offer them ablation if you think that again, prognostication, all those things that you have done, you feel the patient will benefit with treatment, please offer them the treatment as is required. I'll just finish with two cases which are very practical in considering this particular topic. Now, this was a young gentleman, 37-year-old. He had this particular ECG while he was found out palpitation and tachypneic. This was immediately after a gym session that the patient had, and the patient gives a history. Every time he goes to gym, he has the similar symptoms. So thankfully, one time we could get this particular tachycardia. If you see, there is a fusion beat and capture beat and everything which is seen. It is a broad complex tachycardia. He was started on some medication, but he could not be controlled, so he was taken up for ablation. So this was found to be somewhere near the left posterior fascicle. So as I told you, we can map it in 2D. This is the X-ray which we use for 2D evaluation, or there is something called as 3D. So this is a left ventricle which we have created outside the body with the help of the 3D machine. And this point is where the ablation was carried out around left posterior fascicle. And thankfully we could achieve good result. This was maybe 3-4 years down the line, and patient is completely asymptomatic. Now, similar to that, now this particular gentleman, again similar age, but this patient had LV systolic dysfunction. Everything was done, the CAG was done, the CMR was done, thinking that it is some cardiomyopathy, but it turned out to be completely normal. The EF was not very low, 40-45%, but the PVC burden was high. As I am showing you here, the patient is actually having some VT episodes. Now, this particular patient had the focus somewhere around the right ventricular outflow tract on the posterior side. These can be treated with 2D as well, but then 3D helps us. Now, this is the point of ablation is here. That was the earliest point. When you have a 3D system at your disposal, you can actually consolidate that whole area with the ablation lesions, ensuring that the further follow-up patient will not get any PVC. So that is the usefulness of 3D in this particular situation. If you see down here, there are PVCs, and as the RF started, the PVCs went away. That is what we call electrical silence. This is how we generally manage PVCs whenever you are managing it with ablation. So in summary, PVCs are very common. I don't have to tell that. The epidemic is just starting. The more the devices there are, the more will be the PVCs. It can either cause a VT or LV systolic dysfunction. Risk assessment is very important. That is why I have given maximum time in my talk on the prognostication or risk assessment. Management is obviously starts with the lifestyle management, then go on to the medical management, or if the patient prefers catheter ablation, then please offer that, because it's a long-term management for the patient. Thank you so much.
Thank you, sir. We'll take questions at the end of the session. For next lecture, I invite Dr. Rajkumar Ghumre, sir. Topic is sinus node dysfunction.
Okay. Good afternoon again. I know this is a pre-prandial session. Most of us are hungry, so I'll try to be quick. We'll just go around in 10 minutes or so. So these two, from tachycardia now we are moving towards bradycardias, and sinus node anatomy and physiology has already been covered. This is one of the most difficult ECGs we used to face during our UG exams. If we are given normal ECG, I was totally blank, because we are all expecting some AMI, some VT, some AF, and if we are handed normal ECG, it was most difficult. I hope everyone agrees with this. So sinus rhythm, what does that mean? But the rate is between normal sinus rhythm is the rate should be between 60 to 100. Each P wave should be followed by a QRS complex. PR interval should be normal and constant. These are three basic criteria for calling it a normal sinus rhythm. So whenever the sinus node is dysfunctional, we'll have problems with these as expected. So this is the list of sinus node dysfunction. Mainly we can differentiate it into two categories. One is extrinsic and one is intrinsic. The intrinsic dysfunction, that is as a result of fibrosis of the sinus node, is the most common. Clinically significant sinus node dysfunction which you will be facing is because of the fibrosis of the conduction system. May it be sinus node or may it be AV node bundle of phase. So other causes like extrinsic, it may be drugs, myocarditis, ischemia, infiltrative disorders like sarcoidosis, hypothyroidism. These are extrinsic factors, and many of the times history helps us in coming to the narrowing down those diagnoses. So sinus node dysfunction or the sixth sinus syndrome, that can present in these 5 ways to us. It can just present as a sinus bradycardia. It can present with a sinoatrial exit block, just like we have AV blocks, MOBIDs 1, MOBIDs 2. We have sinoatrial exit block. They can present as a sinus arrest. They can also present us with chronotropic incompetence. This is a underdiagnosed entity, I feel, and sometimes as a tachycardia bradycardia syndrome. So sinus bradycardia, very easy to diagnose. The rate is less than 60, but each P wave is followed by a QRS complex. PR interval seems normal and constant. But what with sinoatrial exit block? So sinoatrial first degree SA exit block cannot be seen on, means we cannot interpret on ECG. Just like we have first degree AV block where we can see the prolonged PR interval, the prolongation of transmission of impulse from the P cells, that is pacemaker cells, to transitional. We have something called as pacemaker cells, transitional cells, then we have atrial myocardium. So if there is a problem in the transitional cells of sinus node, we will have prolonged transmission of impulse from the sinus node to atrium. So first degree SA exit plot cannot be seen on a normal ECG. So we have either second degree type 1 and second degree type 2. So second degree type 1, there will be progressive prolongation of PP interval followed by a drop P wave. So P wave, so there will be a group beating, just like we see in Venki back, we also have group beating in SA exit block second degree type 1. Whereas in SA exit block second degree type 2, there will be sudden drop in P wave and QRS complex. The PP interval will be in multiples. So as shown here, the PP interval is exactly double of the previous preceding PP interval. So this is second degree type 2 exit block. And finally, as the severity of the sinus node dysfunction increases, we may see these sinus pauses or the sinus arrest. Usually it is followed by escape rhythm either from the atrium, bundle of E's or ventricular escape. The escape will be seen by preceded by long sinus pauses. Some patients, almost 20 to 60%, on an average 30-40% of patients of sick sinus syndrome may present to us with palpitations. They may present to us with tachyarrhythmia. And after, one clue is if they undergo spontaneous conversion to sinus rhythm, or if we give them a drug, usually they follow it up with long sinus pauses. So that's a marker that the sinus node itself is dysfunctional. So whenever the atrial fibrillation or atrial tachycardia converts to sinus rhythm, many times there will be long sinus pauses. So as we can see in this ECG, we have both tachycardia and episodes of sinus arrest interspersed. Commonest arrhythmia seen in those patients is atrial fibrillation followed by atrial tachycardias and flutters. So chronotropic incompetence, what happens is many patients present to specialty physicians with fatigue or dyspnea on exertion. You have taken done their pulmonary function test, you have done angiogram which was normal, but the patient continues, he is not anemic, we have ruled out other causes. So what we should do in such patients, and heart rate on rest is say somewhere around 55, 60, 62. So such patients you should suspect sinus node dysfunction, and that the presentation may be just a chronotropic incompetence. We may not have other findings on their ECGs or Holters which you have done. So what happens is the patient, chronotropic incompetence is inability of the patient to increase their heart rate in proportion to the metabolic demand of the body. So the target heart rate as per the age, we all know, is 80% of 220 minus age is our target heart rate. So we should achieve at least 80-85% of that. So these patients, either they are not able to achieve that target heart rate, some may achieve it but very late in the study, some may achieve but the recovery is not that fast. So these are various ways the chronotropic incompetence can be seen in these patients. The commonest is they are not able to achieve their target heart rates, and because of which they are symptomatic. Also, I thought I'll just go in brief through the AV blocks also. So these are the list of AV blocks, again similar causes. First degree AV block we all are familiar, prolonged PR interval more than 200 milliseconds. Again, it is usually a benign finding and does not require treatment. Venki or the Mobitz type 1 block, there is progressive prolongation of PR interval followed by a drop beat. PR interval longest immediately after the drop beat, the PR interval will be the longest, and shortest, it will be the shortest if in the immediately after the drop beat. See, the PR interval is longest immediately before the drop beat, and if you look at the PR interval, it is shortest immediately after drop beat. This is the Venki back is usually at the level of AV node, what we call as in suprahesian block. So it is more benign when we compare it with Mobitz type 2. In Mobitz type 2, PR interval in the conducted beat is constant. There is sudden drop of sudden unpredicted. So you don't see a pattern, that is there is a progressive prolongation of PR interval which we see in Mobitz type 1. Here there won't be a pattern, there will be sudden drop in P wave. So this is the Mobitz type 2 is more likely to be, it can be in the node or it can be the below the node. So this is more, the Mobitz type 1 I would say is more benign as when we compare it with Mobitz type 2. High grade or advanced AV block in which 2 or more P waves are not conducted, they have very high likelihood of progression to complete heart block, and again these are the patients who are more likely to need a pacemaker. 2S21 AV block is a separate entity. It can either be a Mobitz type 1 or type 2. So how to differentiate whether this is benign or more likely to progress towards serious blocks? We look at the QRS complex, look at the PR interval. If the PR interval is prolonged, the QRS duration is wider, the block is more likely to be at the level of more likely to be below the node. If the QRS is narrow, PR is shorter, and on exercise, if we subject these patients to either a stress test, the block may either disappear, block may even disappear. But in patients who have infrahesian blocks, the block may worsen. So these are the various ways which we can differentiate the 2S to 1AV block. And finally, complete heart block with the PP interval constant, RR constant, bradycardia, and we can see the P wave marching through the QRS complex. If patients of atrial fibrillation who is on drugs, maybe amiodarone, beta blocker, digoxin, if they present to us with a regular RR intervals on ECG, suspect complete heart block there, because it's very, very rare to have a regular rate in patients with AF. So we should have a strong suspicion of complete heart block if patients of AF have. I think fascicular blocks have already been covered, fascicular and bundle branch blocks, I think sir has covered. Just this is a trifascicular block, wherein the patient has prolonged PR interval, first degree heart block, right bundle branch block, and at the same time a left anterior hemi block. These patients are very likely to progress to complete heart block, and they should be, if symptomatic, they should be offered pacemaker at the earliest. And last ECG which I have, this is you can see that this is a case of, if you look at V1, we have both right bundle branch block and left bundle branch block. This is an alternating bundle branch block. It suggests advanced disease of the conducting system, and these are the patients who should be offered early pacemaker again if they are symptomatic. Again, when we look for the management of such patients, especially in patients of sinus node dysfunction, assessment of their symptoms and correlation with what we find on ECG is very important, because many of these patients, they may have sinus bradycardia, short sinus pauses on Holter, but the symptoms may not be correlating to what we find on ECG or Holters, and they should not be offered pacemaker, because sinus node dysfunction per se is a relatively benign entity. Whenever we offer them pacemaker, it is more for elevation of symptoms, more for improvement in quality of life if we are offering for chronotropic incompetence. Whereas in AV blocks, mortality benefit, whenever we offer them pacemaker, we are offering more for mortality benefit in addition to elevation of symptoms. So we'll look for reversible causes and treat them accordingly. Like in this patient, he had hyperkalemia, which was treated and patient recovered. In sinus node dysfunction, we prefer nowadays dual chamber pacemakers, because in patients, if we offer them nowadays single chamber pacemakers for sinus node dysfunction are practically not offered. They can be given, but what happens in future, these patients are very likely to progress to AV conduction. Almost 40 to 50% of patients progress to AV node disease also. It's better to offer them dual chamber pacemakers. In AV blocks, again, second or third degree AV blocks who are symptomatic and not attributable to any reversible causes should be offered permanent pacemakers. Bundle branch block, these patients you are likely to see in OPDs. So patient who has a right bundle branch or a left bundle branch block, and if he presents to you with syncope, and if you have not found anything on 24-hour Holters or ELRs, they can be subjected to an invasive EP study, and we may would like to find out if they have prolonged HV intervals. If patients with bundle branch block, syncope, and have prolonged HV intervals, that is the intrinsic conduction from the bundle of his to the ventricle, if that is prolonged, they are safer to be offered a pacemaker. So in congenital complete heart blocks, if the patients are symptomatic, if the escape rhythm is broader, if they are having dilatation of the ventricle, if they develop LV dysfunction, if the rates are going below 50 consistently, then in that case they should be offered pacemakers, because many times we see asymptomatic congenital CHBs, normal LV size, they can be just followed up clinically. Thank you. The claps were probably because I was fast.
Thank you so much, sir. We can have questions. Thank you, sir. For next lecture, I invite Dr. Ashish Nabar, sir. Topic is heart failure and LV dysfunction advanced treatment options.
Dr. Harkut is normally a cool guy, you all know, but just now he is very disturbed because I am standing between you and the lunch. So he has clearly warned me to keep that perspective in mind. But since the crowd has not dwindled, just like the previous two speakers, I have taken heart that they are really here to listen. But don't worry, I will try and keep the perspective. Can we have it there? क्या करना है? So basically the advanced treatment of heart failure is in relation to how we want to use the electrical implantable devices, the pacemakers and ICDs for the benefit of treating heart failure patients. And Dr. Narasimhan, and then in my last lecture we delved with, I think, quite a bit on what a physician needs to know about cardiac resynchronization therapy. And this is something different. This is conduction system pacing. So this is new, and this has really caught the imagination of the practicing electrophysiologists world over, also in India. So once again, thanks for the invite. This is what I also showed in the previous presentation, that as the QRS gets wider, the survival tends to dip in patients who have heart failure. So 170, 220 millisecond wide QRS is bad, and you really need to think what kind of electrical implantable device would come good for this patient. So in CRT, what you do, to recapitulate, there is a lead in the RV at the septum, and there is another lead in the coronary sinus, and stimulating the LV from both sides, you tend to synchronize the left ventricular contraction. Isn't it intuitive to think that if you put a lead in the conduction system, you would narrow the QRS still more? Yeah, that's quite intuitive, because normal activation from the conduction system results in a QRS which is 80 to 100 milliseconds. So if you can pace the ventricle by putting a lead in the conduction system pacing, that would probably give you the narrowest QRS and narrow the QRS better in heart failure patients. So that's true. So this has lately got into practice, and you can either put that lead in the his bundle, or you can put the lead down in the left bundle, and pacing from there you expect to give a narrow QRS. Now I'll take his bundle pacing out of the discussion, because left bundle pacing is much more simpler for the electrophysiologist. The learning curve is short, there is less chance of lead dislodgement, thresholds remain stable in long term, and there are less issues like oversensing. So where can we do the conduction system pacing or left bundle branch area pacing? That is, where can you pace the left bundle? How can you pace the left bundle? Which patients can you do that? So basically, you can do that in almost every patient who requires a RV pacing or has a Brady pacing indication, so that you give a narrow QRS right from the start that the pacemaker is inserted, and hopefully that narrow QRS will prevent a LV dysfunction happening because of pacing. That is called pacing induced cardiomyopathy. It can be used to narrow the QRS in a heart failure patient so that you improve the heart failure status, or it can be used to treat a patient who has developed a pacing induced cardiomyopathy. So in short, we are probably talking of replacing the RV pacing by conduction system pacing in every patient, and the electrophysiologist today loves this concept. So let's discuss some of the cases where we decided to do conduction system pacing in patients who have heart failure or LV systolic dysfunction. As I already started saying, that cardiac resynchronization therapy is an established therapy where you do RV and coronary sinus pacing and give a narrow QRS. But as you can see on this ECG, every time the QRS does not narrow to the best that you would want, and then there are questions left whether this CRT would result in a responder status in the heart failure patient. So here is the first case where a relatively young lady 43-year-old has LV systolic dysfunction with the EF down to 25 to 30%, a moderate MR, and definitely symptomatic. And that's the QRS where there is a LBBB which is reasonably above 130 milliseconds, and therefore the referring cardiologist wanted to do a CRT. Now this is the CRT that I did, and you can see that there is a very big coronary sinus vein, and normally I should be easily able to get my lead down into that. But what would happen is every time I withdrew that sheath which is used to deliver the lead, the CS lead would come back, and this happened 5 times, and I was at wit's end how to do this, and therefore normally in the previous days I probably would have had to quit, but today you can do this conduction system pacing wherein you drive this lead from the right side of the septum into the septum to capture the left bundle, and the resulting QRS was something like this. Now not too brilliant. When it is not too brilliant, we call it deep septal pacing. You put the lead into the septum, and because the activation starts from the interventricular septum and it activates both the ventricles simultaneously, your QRS tends to be narrow. So we don't know whether it is the most ideal way to have done the left bundle branch area pacing, but in a few months time this patient, I was told, has a reduction in MR, improvement in ejection fraction, and a symptom class. So this is deep septal pacing and did work as a fallback option when I couldn't complete the CRT. Another case, very classic indication. So here if you see, there is I'm trying to deliver the lead in the vein here, the coronary sinus vein, but the coronary sinus got dissected. Happens once in a while with the sheaths that we use. Now, once you have a dissection, you can't see that branch and you can't deliver the lead anymore. So therefore I had to fall back and do a conduction system pacing, resulting in this kind of a QRS, which is much more narrower QRS that I could have expected with even a CRT, and this patient does turn out to be the responder. So what I showed you in the last 2 cases is you can achieve a cardiac resynchronization by conduction system pacing, but in these 2 cases at least I used it as a fallback option. My intention when going in was to do a CRT, but I couldn't deliver the CS lead and I did a left bundle pacing. There are a lot of benefits. If you look in the last column, there is a fluoroscopy time which is less, the thresholds are better, the hemodynamic effects are better, the QRS is more narrow, the ejection fraction improves. So all that benefits are there by conduction system pacing or left bundle branch area pacing above the CRT. Most important for me here is that you can do the procedure faster and keep the patient on the table for much shorter time. And that's what I used here. Now 85-year-old lady who has everything, complete heart block, non-sustained VT, low ejection fraction. So she deserves a CRT-D provided you know she is vital enough and has had a good pre-morbid quality of life. So here we did some kind of a jugaad. What is that jugaad? You have a VDD lead which works as a ICD. So you have the ICD lead down and you have, sorry, I'll get this then. So you have the ICD lead which is having a floating atrial dipole. So I have saved one lead, and this is the left bundle branch area pacing lead which gives a QRS which is seen on the right side. So if you have that kind of a QRS, you have achieved almost everything. You have achieved pacing, you have achieved a narrow QRS. So you have achieved heart failure pacing, you have achieved Brady pacing, and you have ICD lead as a prevention to sudden cardiac death. So you can get this patient off the table, a 85-year-old lady with a creatinine of say 2, who would have required a lot of contrast to put a CS lead, you can get her off table with less chance of complications. So therefore left bundle area pacing is clearly superior because it reduces the QRS, gives the optimal position of the lead which is stable, which has less complications while doing the procedure. Now what is the difficulty in doing this in preference to CRT all the time? Why not do conduction system pacing for heart failure instead of doing CRT? Because it is faster and it is even cheaper, because you are going to use a dual chamber pacemaker generator and not the CRT pacemaker generator, which is much costlier. So why not do it in preference? The reason is following, that most of our studies, although they have showed benefit in terms of reducing the heart failure hospitalizations, reducing the death. The difficulty is that these are all observational studies. All are observational studies. So despite the clinical benefits which seem to be equivalent to CRT, these benefits are only observed in observational studies. We do not have RCTs or randomized controlled trials. There is recently a meta-analysis which is done, which has shown, meta-analysis as you know is multiple trial patients are pooled together and then you analyze them, and that has shown that the QRS duration, the NYHA class is better, the ejection fraction is better. So we are gathering evidence to show but at this point in time the CRT is always your first recommendation and the conduction system pacing comes in specific situations. So is conduction system pacing really easy? If you look here, this is the left side of the heart. Between the non-coronary and the right coronary cusp, we have a left bundle exiting which then divides into left anterior and posterior fascicle. You can pace anywhere here to achieve a conduction system pacing. Do I have a great roadmap? Not really, because I have to sample sites where I screw from the right side of the septum to the LV subendocardium, hoping to capture the conduction system. Only if I fall along this, then I can get a conduction system pacing. If I fall here, here or here, I will have a wide QRS and I must keep trying again. So because of the variation in the anatomy of the left bundle, it does take some trial and error to get the conduction system pacing. Now we call it left bundle branch area pacing and not left bundle pacing, is because depending on how deep, which place you select to start screwing your lead from right side into the left side, you may get either a left bundle branch, left anterior fascicle, left posterior fascicle, or you may just be spacing myocardium deep into the septum, and depending on how deep you drill in, you will capture the conduction system or myocardium along with the conduction system and things like that. So therefore, this is the generic term that is used, left bundle branch area pacing. And there is a ECG way to find out where exactly you are pacing, left bundle or left posterior fascicle or left anterior fascicle. The difficulty with the biventricular CRT is that you have non-responders for various reasons. And therefore, there is a case for doing what is called as a lot CRT, meaning you combine the pacing from the coronary sinus and the conduction system to give still better result. That means that a left bundle branch area pacing is itself not enough if the myocardium is diseased, because you may capture the left bundle but the conduction delay in the myocardium still doesn't allow you to get the narrow QRS that you intended to. And therefore, once again, I think third time since morning, we are talking of cardiac physiologic pacing, which means that you pace in the coronary sinus and in the RV instead of endocardium, you drill this lead to achieve conduction system pacing. So conduction system pacing plus CS pacing might give you a real narrow QRS. So the state of the art today is quadripolar lead in the coronary sinus, and if required, the RV lead as a conduction system pacing to give you the most narrow QRS. Now let's have some of the cases, a couple of that I discussed. This is a classic non-ischemic cardiomyopathy patient with a left bundle branch block, a lady who usually females have much better results of CRT pacemaker. So here is a very standard indication with a left bundle branch block. Easily you would say that this is the best indication to do a CRT pacing. In this case, we did what is cardiac physiologic pacing. So here you can see that there is a lead in the coronary sinus, a quadripolar lead, a lead drilled into the septum to achieve a conduction system pacing, and this is the QRS that you get. A pretty narrow QRS at that, and you can only expect that this heart failure patient would be responder. The non-ischemic cardiomyopathies are more likely to be responders than ischemic cardiomyopathies. So you can better the result of the conventional CRT by doing what is called as a lot CRT. So if you see here, there is this lead which is put in the left bundle branch area, and then there is a lead which goes into the conduction system. So here, for example, I did the conduction system pacing and I would have loved to do this lead, but this would just not go because it's a very small vein, and this vein although could be wired, but this lead would not go down, and therefore I had to put this lead in a less suboptimal vein. So this is posterolateral vein which is ideal to put the CS lead, and this is the posterior vein which is a little less ideal. So sometimes you don't get the best vein to put your CS lead, and that time this conduction system pacing lead allows you to achieve more synchronization. So sometimes it is add on, sometimes this is cardiac physiologic pacing which really helps you to give the most narrow QRS and complete the CRT to give again a very narrow QRS at that, and you can probably expect a responder status here. How about dealing with patients who have a non-LBBB kind of a QRS? If you remember in the previous discussion, I said RBBB left axis might just work, or IVCD with a QRS more than 150 milliseconds might just work. So again, can this concept, does this conduction system pacing do better than the CRT? There is still doubt as to whether it will, but definitely there is an option now that you can either do conduction system pacing or combine it with the CS lead. Switching gears here, pacing induced cardiomyopathy. Many of the people still have this habit of putting the lead, just a shift here is whether you can do conduction system pacing to prevent pacing induced cardiomyopathy. So you have a 85-year-old lady with permanent AF and the kind of a fixed slow QRS that Dr. Rajkumar showed, a complete heart block. Now here there is no point doing a dual chamber pacemaker because the atrium is in permanent atrial fibrillation. So you are doing a single chamber pacemaker. Now because of AF you already have AV dyssynchrony. On the top of that, if you put your RV lead in the apex, you are going to create a VV dyssynchrony, and this will definitely lead to worsening heart failure or worsening LV systolic patient, worsening LV systolic function in this patient who otherwise didn't have to start with. So here we decided to do a conduction system pacing and give a narrow QRS, and hopefully you have at least not brought in the ventricular dyssynchrony. AV dyssynchrony will tend to persist. Another higher age lady who has a tachycardiomyopathy when she has recurrent ATAF. So depending on what kind of ATAF is there, if a patient requires a pacemaker, or this patient is probably ATAF with persistent episodes, persistent ATAF episodes. So say whenever she gets into ATAF, she gets into a tachycardiomyopathy. So here the best treatment is to ablate the AV node and put a pacemaker. But again, if you put a normal kind of a RV endocardial pacing with a wide QRS, you'd probably land up with a tachycardiomyopathy or pacing induced cardiomyopathy. So you would exchange a tachycardiomyopathy for pacing induced cardiomyopathy. Instead of that, if you do conduction system pacing after ablating the AV node, you probably would result once again in a narrow QRS like this, and whenever she's in sinus rhythm, she may has the Ascens V pace. This V pace is with a narrow QRS, so hopefully you would not give this patient a pacing induced cardiomyopathy. Again, this is a more upcoming indication. More and more trans aortic valve implantations, the TAVIs are done, and the valve presses on the conduction system when it's implanted can result in a complete heart block. The numbers are few, 2 to 5% maybe. Also the surgeon knows that when he does aortic valve replacement, you can have a complete heart block. Many times these patients already have some kind of a LV systolic dysfunction. You have to now per se give a pacemaker. I would prefer that these patients get a conduction system pacing so that you can give a narrow QRS. You can see the valve here. That valve like this, the prosthetic valve or the TAVI valve tells you where the conduction system is roughly. You can probably achieve a conduction system pacing and prevent a pacing induced cardiomyopathy much easily. Again, you have congenital complete heart block patients. If you pace them for good number of years, say from the age of 10, if you have to pace them till the age of 60, 70, you are bound to, you think you are more bound to get into a pacing induced cardiomyopathy. So younger patients, this Medtronic lead is pretty flimsy, can give that alpha loop, and you can give a narrow. So this patient has a ASD closure as well as a balloon pulmonary valvotomy done and has a complete heart block. So at a later date, we gave him a conduction system pacing with a single chamber device, because kids usually if they are small, we don't do dual chamber devices so easily. A narrow QRS like this would help matters. Last thing is pacing induced cardiomyopathy. Many times the pacemakers are done with the RV lead in the apex. You get a wide QRS. This patient landed up with a pacing induced cardiomyopathy within a few months. Sometimes they get pacing induced cardiomyopathy after many years. So if they get a LV systolic dysfunction with a QRS like this. So this is what I don't like nowadays. A wide paced QRS like this, you are always worried that there is some incidence of clinical or subclinical pacing induced cardiomyopathy. So we extracted this lead out, gave a conduction system pacing lead as you can see there, and again narrow QRS at the end of it, and the ejection fraction reversed very well. So there are certain concerns with conduction system pacing in terms of how the lead will work when it is hitched to the, when it is into the myocardium like that, whether for some reason if you need to take this lead out, whether it will be easy, what does it do to the tricuspid valve and things like that. So there are certain concerns. It's work in progress whether you should do them for all patients, but definitely this is a promising tool for brady pacing as well as for heart failure related pacing, and it is mainly left bundle branch area pacing that we are talking of, rather than his bundle pacing. So I think I'll stop here, and Dr. Harkut can say where do we go from here. Thank you.
Thank you, sir. Any questions? Thank you, sir. Now we can have a lunch break and meet again for panel discussion and quiz.